hepatology. And if you find a case of steatotic liver disease, so the presence of any other cardiometabolic criteria, if it is yes, then if it is no, then definite. So if it is if it is yes, presence of alcoholic consumption more than 20 gram per day in women and more than 30 gram per day in men. If it is no, then it is MSLD. So this in MSLD, if inflammation is there or ballooning on stool is there, then this is called MAS. So if there is no history of again alcohol consumption, you have to find out the other causes of steatosis, either DILI or monogenic or miscellaneous, or you can call it a cryptogenic SLD. If the alcohol intake is more than 50 gram per day in women, more than 60 gram per day in men, if it is yes, then you call it a alcoholic liver disease. If no, then there is another term also, it is called a MET ALD. So this MSLD with alcohol, this alcohol, then it is called MET ALD. So these are the various terminologies that has been come out, and this is recently published in 2 months back by ESL Journal of Hepatology. So what is the real prevalence of MSLD in diabetes? Because we are talking of MSLD and diabetes. So recent studies suggest that in the United States, up to more than 70% of people with type 2 diabetes have hepatic steatosis. Just imagine what is the real burden. Almost 70% of type 2 diabetes people, they do have MSLD. And driven by insulin resistance, steatohepatitis develops in at least half of all people with type 2 diabetes and is a significant risk factor for future cirrhosis. Steatohepatitis is believed to be the link for the significant increase in the rate of hepatocellular carcinoma observed in people with diabetes. It's not uncommon, it's very common. I have at least within the last 5-7 years, I have lost 3 of my dear and near people regarding this MSLD leading to cirrhosis, leading to hepatocellular carcinoma. So this is the prevalence of NFLD, so-called MSLD, in type 2 diabetes patients observed in several authors in India. You can see these are the various collateral they have shown. In North India, the prevalence is 72%. Here again, the same group in South India, they have found it is almost 60%. And in the East India, it's 55%. West India, it is 44%. And these are the other authors. That is the Laltesh Kumar, they have found in North India almost 72%, and West India, Bhatal, they have 45%, and Rohin et al., South India. So you see, in India also, the prevalence of MSLD in diabetes varies from 50 to 70%. So it's a really, really worrisome from us, because we know as per our that is almost 9 to 10% in India, the people, they do suffer from diabetes. So you see, this is a huge burden. MSLD is the most common chronic liver disease in people with type 2 diabetes and may be considered relatively new complications. Diabetes is again a major risk factor for developing MAS disease. Not only it is associated, it is found in diabetes, but if MSLD is found in diabetes, that means the disease progression is very fast, the disease severity is very fast, and there is a worst outcome both in case of as cirrhosis as well as hepatocellular carcinoma. So MAS is estimated to affect more than half of people with type 2 diabetes with NFLD, and so people who are having MSLD, almost half of them even go to either MAS or cirrhosis. So what's the pathogenesis is short. So insulin resistance is the main driver. So the strong epidemiological biochemics of the primary pathophysiological regimen is most patients with MSLD is insulin resistance. And that insulin resistance leads to increased lipolysis, triglyceride synthesis, increased hepatic uptake of free fatty acids, and accumulation of hepatic triglyceride. So several fat-derived hormones such as adiponectin, leptin, resistin, they are also important regulator of the hepatic insulin sensitivity. And the second is hepatic inflammation and fibrosis. So insulin resistance, hepatic inflammation, fibrosis, these are the common pathways of leading to this MSLD and MAS. Several possible mechanisms have been theorized, including host factors such as defect in the mitochondrial structure function, impaired free oxygen radical scavenging, increased hepatic iron, and hepatotoxic byproducts of intestinal bacteria. So these factors also involved in hepatic fibrogenesis are slowly becoming understood. Now, activation of both lobular stellate cells, this is the hepatic stellate cells, they play a key role in this process of fibrosis. So not only that, MSLD is found almost 50 to 60% in diabetes, but the other way is also true. NFLD or MSLD itself, that increases the risk of type 2 diabetes. So the prevalence of diabetes among this MSLD and NAS people is estimated to be almost 22% and 43%. So that is much higher than the prevalence of diabetes in the general population, at least 8 to 9%. But people who are having this NFLD or MSLD, in those groups, the diabetes occurs in 22 to 43%. So indeed, prior to the onset of diabetes, the presence of NFLD itself is associated with insulin resistance and developed nocturnal blood glucose. It has been reported that NFLD increases the risk of cardiovascular disease by 1.96 fold, chronic kidney disease by 1.87 fold, and proliferative that is retinopathy by 1.7 fold, and distal symmetric polyneuropathy by 5.3 fold. So you see, MSLD is a risk factor for all these complications of diabetes through. So many fold they are increased. So this is in a picture that I have shown. You must have almost everybody has come across how this normal liver to the MSLD or NFLD, NAS and fibrosis. So I don't want to go to details on all the. Again, coming to the fibrosis stage. So fibrosis stages are again classified histologically as the following. F0 is no fibrosis. This is the histological classification, of course. F1 is mild, F2 is moderate, F2 is moderate but significant, F3 is severe, and F4 is cirrhosis. So 12 to 20% of people with type 2 diabetes have clinically significant fibrosis, that is the range of F2, and MAS is leading cause of hepatocellular carcinoma. So how to risk stratify? The whole problem is, so this is the real story we should all adhere to. So how to at least risk stratify these diabetes patients who are having in which stage, and in our clinical practice it should be very easy, so that in our clinic itself we can at least know really what is the risk of this patient and what I should do. But it seems paradoxical. Even all of you will agree with me, none of us, most of us, we really risk stratify so-called is MSLD is concerned. We see a lot of diabetes patients, but how many of us really do this risk stratify for MSLD? So definitely that is a very paradox. So whether in primary care or diabetes specialty clinic, few patients are stratified for their risk of cirrhosis. So it is estimated that poor management of comorbidities in the people with MSLD accounts for as much as 66% of all cause death and 83% of cardiovascular death in this population. So what are the recommendations? The recommendation is adult with type 2 diabetes or pre-diabetes, particularly those with obesity or cardiometabolic risk factors. You see 85% of the diabetes people either they are overweight or obese. So almost every diabetes patient should be screened for or stratified for clinically significant liver fibrosis using a calculated fibrosis 4 index, that is what called F4 index. So this should be done in our clinic by for every diabetes patient by every clinician. because this is very simple. We know what is age, we know we can think of ALT and AST. For CBC we can find out the platelets. So these are the four criteria are needed to calculate FIFO score. And you see, this is, you can just click this link and you can find what is the FIFO score. If you click this link, then you can find like this. This is the FIFO index for liver fibrosis. You can put your age, you can put the AST, ALT, platelet count, and the result will be coming like that, either less than 1.3 or more than 2.7. So the risk is, if it is less than 1.3, the risk is low. If it is more than 2.67, the risk is high. So 1.3 to 2.6, it is indeterminate. So this is how you can risk stratify every patient in your clinic. This is very easy. From your only Android telephone or phone also you can do, and you can know what is the risk of this, my patient, so far as this liver is concerned, or MSLD and NAS or cirrhosis is concerned. So adult with diabetes or pre-diabetes with low FIFO should be evaluated for other causes of liver disease, and this should be follow up. If it is less than 1.3, then we should follow up, and we also find out is there any other cause. But those who are the indeterminates, that is between 1.3 to 2.6 and 5, then they have to be again followed up very seriously, and you can go for the other way, that is elastography. Adult with type 2 diabetes or pre-diabetes with indeterminate results or at a high risk for significant liver fibrosis should refer to gastroenterologist. Those who are more than 2.675, they should be evaluated further, and you can refer the patient to the hepatologist. So this is the algorithm. This is again, you see, if there is a type 2 diabetes, or this is non-diabetic people, of course, obesity with plus minus cardiometabolic risk factor or persistently elevated liver enzymes. So either of the three, then you can do you should do the FIFO. If it is less than 1.3, then reassess FIFO every 1 to 3 years. If it is more than 2.67, then you should refer the patient. If it is indeterminate, again, so you have to intensify management of comorbidities. So if it comes down to less than 1.3, wait, reassess. If it continues more than 1.3, then you should go to the, that is what we call the other test to know that is the VCT. So here you see, if it is, again it is called the KPA, it is less than 1.8, you can come do intensified management. If it is more than 8, again you have to hepatology referral. So this is the transient elastography. We all do also transient elastography. So in this stage, you can go for the transient elastography and find out what is the real risk. So when you risk stratify, then what should be our plan of management? Adult with type 2 diabetes, MSLD should recommend lifestyle changes that promote weight loss. So weight loss is very, very important. Ideally within a structured nutrition plan and physical activity, a minimum weight loss of 5%, preferably more than 10%, is needed to improve liver histology with fibrosis. So weight loss is very important. Now, this is the study which shows the effect of the magnitude of the weight loss on non-alcoholic fatty liver disease. That this is a systemic review. So what they have found, clinically significant improvement in FLD are achieved even with modest weight loss. Every 1 kg of weight loss is also important. Every 1 kg. So modest weight loss is very important. Every 1 kg of weight loss is associated with 0.83 unit of reduction in ALT, 0.56 unit of reduction in AST, 0.77% point of reduction in steatosis is assessed by radiology. So friends, every kg of weight loss is very important. So you have to lose weight and lose weight. And adults with type 2 diabetes, particularly the overweight or obesity, consider using GLP-1 receptor agonist with demonstrated benefit. All of us know how these GLP-1 agonists are important, and this article shows a placebo-controlled trial of subcutaneous semaglutide in non-alcoholic steatohepatitis. That shows, you see, but this primary endpoint is, you see, this is the primary endpoint. Here what happens? The resolution of NAS with no worsening of liver fibrosis, primary endpoint, this is achieved, but unfortunately the fibrosis stage, that there is no improvement with fibrosis. That's why it is of use, but again it's not approved by US FDA for use, but we can use this because this has got multiple advantages. That is, you have to control of blood sugar, weight management, and other ASCVD risk factor management, and side by side also this achievement is there. So study overview: patients with non-alcoholic steatohepatitis randomly assigned to receive subcutaneous semaglutide placebo, and the incidence of NAS resolution was significantly higher with semaglutide than placebo, but with between group differences in the incidence of improvement, the fibrosis stage was not significant. Again, pioglitazone, all of us know, this is also preferred agents, but we have no using this. But again, though many trials have shown that the advantage of pioglitazone, but still due to its adverse, that is the bladder carcinoma and also the osteoporosis, there are so many other factors that are not approved by US FDA, but these are the drugs, at least for anti-diabetic drugs we should use. And this study shows first in Asian people, it's a double-blind randomized trial to assess the efficacy and safety of insulin sensitizer in non-alcoholic steatohepatitis hepatitis patients. And you see here a 24-week pioglitazone treatment was well tolerated, effective in improving the histology and reducing the liver steatosis in Asian patients. Now insulin is again the preferred agent for the treatment of hyperglycemia. And adults with type 2 diabetes, MSLDR, increased cardiovascular risk, therefore comprehensive management cardiovascular risk factors should be also taken care of. Statin therapy is very safe, but it should not be used in decompensated cirrhosis. Now consider metabolic surgery whenever required, and that is also very, because that also leads to not only weight loss, there are other many advantages for metabolic surgery again, but in decompensated disease, metabolic surgery is not indicated. So friends, what is the new? Because till date we didn't have any drugs that is US approved and FDA approved for treatment of this group of patients. Then what is new? This is a recently published February 8, 24, a phase 3 randomized control trial of resmetirom in NAS with liver fibrosis. So resmetirom, again this is a thyroid receptor beta agonist. This has been tried for the control of the NAS with liver fibrosis. And this has shown, you see, this is a phase 3 randomized control trial of resmetirom in NAS with liver fibrosis. What is found in conclusion? In particular, with NAS and liver fibrosis, once daily treatment with resmetirom was superior to placebo with respect to NAS resolution and fibrosis improvement by more than one stage at 52 weeks of follow-up. So this is a drug found recently that has proved fibrosis. So taking into consideration this drug, both the 80 milligram dose and 100 milligram dose of resmetirom were superior to placebo with respect to NAS resolution and improvement in liver fibrosis by at least one stage. So this is the first drug which has been proved to improve fibrosis in this group of patients. So taking into consideration, FDA approves the first treatment for patients with liver scarring due to fatty liver disease only on 14th March of 2024. So the US Food and Drug Administration approved, that is called the resmetirom for the treatment of adults with non-cirrhotic liver, non-alcoholic steatohepatitis with moderate to advanced liver scarring to be used along with diet and exercise. So friends, now what is the take-home message? MSLD is found in around 50 to 70% of type 2 diabetes patients in India. MSLD in diabetes can fast progress to MAS and cirrhosis. P4 scoring should be done in all type 2 diabetes patients, and LSM and weight loss is essential for MSLD management. Anti-diabetic drugs like GLP-1 receptor agonist and pioglitazone are helpful for MSLD and MAS management. When approved locally and dependent on the level, adults non-cirrhotic MAS with significant liver fibrosis more than stage 2 should be considered for treatment with resmetirom. Thank you.
Thank you, sir, for our excellent presentation. Any question for our audience?
No. We have never missed. You see, we had NFLD. So NFLD has been again re-terminated as MSLD. So NFLD, what happens? NFLD is a non-alcoholic fatty liver disease. So there is a concern. So what is the real quantity of alcohol? That should be less, number one. Number two, it's a disease of exclusion again. That was a disease of exclusion. But MSLD, this is something steatosis with having metabolic risk factors, then you call it MSLD. So this is a new definition, new terminology, and this is found to be more associated with diabetes. That's why we are concerned how we should take care of, how to stratify, how to manage this piece.
Sir, what is the role of saroglitazone? You didn't focus about saroglitazone.
You see, yes, the disease as I approved for this in India, but it's globally not accepted now. And yes, as it is approved by DCGI, you can use not in NAS, in the NFLD patients, you can use this saroglitazone. But that is not approved by that globally. But yes, in India we can use it.
Thank you. Thank you, sir.
Okay, thank you.
The next speaker is Dr. Jugal Kishore Sharma. He is the medical director in Central Delhi Diabetes Center, New Delhi, and is the founder and secretary of General and Innovative Physicians Forum. He is the IPF Global Ambassador, and he is most important. He is the organizing secretary of RSSDI 24 Annual Conference at Delhi. He will tell about testosterone, when, whom, and how. Over to you, Dr. Sam.
Thank you, sir. Good morning to all. लॉर्ड जगन्नाथ के चरणों में नमन करते हुए अगले 20 मिनट मैं आपके साथ एक ऐसे टॉपिक की बात करूंगा जो आप सब जानते हैं. इट इज़ जस्ट ए रिवीजन एंड इट इज़ वेरी वेरी इंपॉर्टेंट. टेस्टोस्टेरोन, वी ऑल नो व्हेन, whom and how to use it. We know that testosterone is a major sex hormone in both men and women, influencing several neurotransmitters including the dopamine and the GABA, and with its level highly correlated to motivational behavior in status seeking and status maintenance in social groups, leading to cooperative, fair and reputation seeking behavior. And nowadays a number of conferences are going on, and you can see all the organizers, I think their testosterone level must be quite high, or they have to keep it. When we go back to the history of testosterone, in 1849, Berthold transplanted the testes from roosters into the abdomen of capons. In 1935, testosterone was obtained in crystalline form from bull testicles, and also it was chemically synthesized. Longer-acting testosterone esters were prepared in 1957, and in 1986 and 1992, transdermal testosterone patches applied to scrotal or the non-scrotal skin, and these transdermal patches are available as of today also. In 2000, transdermal testosterone gel was started. Testosterone is produced, the hormone, by testes and the adrenal gland that has many effects throughout the body. And it is controlled by the hypothalamus pituitary testes axis on the Sertoli cell proliferation. So brain, hypothalamus, that is the main point, from the anterior pituitary, then going to the leading cells, and then the Sertoli cells from where it is being formed. And this is the biosynthetic pathways of testosterone. Look at the cholesterol, which is at the top. Nowadays, you must be seeing that we try to bring down LDL and the cholesterol to a much lower level. Even people say, those who treat cardiology and those who treat the dyslipidemia, they said that this LDL should be as low as possible, even below 30. But what is going to happen to our testosterone level in that situation? I don't think they have any time thought about that. So this is the pathway of testosterone biosynthesis. It influences the body morphology in various functions. The most important is the sexual function, the mind and the body. It regulates the penis and the scrotum formation, stimulates prostate and genitals during the puberty, influences sexual behavior and maintains sex drive, sperm count and the fertility. On the other aspect, regarding the mind, it helps to maintain a feeling of well-being, influences cognition skills. There are decreased verbal abilities, increased spatial orientation, mental rotation, modulates mood and behavior. It increases aggression, decreases anxiety, and also decreases depression. And on the body, it helps to maintain healthy bones, muscle growth, beard, chest, and axillary hair growth is stimulated, and it induces the male typical pattern of baldness and influences male voice. There are certain factors which affect the testosterone, like the endogenous and the exogenous. The endogenous are the sex hormone binding globulin levels, testosterone production, testosterone degradation, then testosterone metabolism. And on the exogenous, if there is stress, there is a role of diet, weather, sexual stimuli, physical activities in sport, and the hormonal supplement contraceptions. Not only men, equally important, the testosterone is there in the women also. In men, it is from the adrenal gland and the testicles, and in women, it is from adrenal glands and the ovaries being produced. And the clinical significance is, in women, testosterone is produced by the ovaries and by the peripheral conversion of androstenedione and dehydroepiandrosterone DHEA, which are pre-androgens synthesized by the ovaries and the adrenal glands. The pre-androgens contribute about 50% of the circulating testosterone in pre-menopausal women, and the concentration of testosterone first begins to increase in girls at about the age of 6 to 8 years. Cyclical production of testosterone by the ovaries starts with the onset of ovulation. Concentrations peak mid-cycle and remain high during the luteal phase. And these are the various causes of low testosterone in women. Spontaneous causes of androgen insufficiency, that is the natural decline, hypothalamic amenorrhea, primary ovarian insufficiency, and then there are certain iatrogenic causes of androgen insufficiency also, like the surgical menopause, chemotherapy, radiotherapy. So maximum concentration of testosterone are achieved in the third and fourth decade, followed by a steady decline in testosterone and its precursors with the increasing age. What are the symptoms? Low libido, weight gain, changes in the mood, hair may begin to thin, your skin may become dry, lose muscle mass. So if any female coming to us in the particular age group with all these vague symptoms, at least we must go for looking for what is the status of the testosterone. Not only low, the high testosterone level is also troubling, like excess acne, abnormal hair growth throughout your body, male pattern baldness, and a deeper voice, menstrual irregularities are there. Now coming to testosterone in the bone health, osteoporosis, which is a progressive metabolic disorder characterized by reduced bone mass and destructive bone microstructural changes, age-related testosterone deficiency is the most important factor of bone loss in elderly men. And we all know that. I don't know how much is being used now or earlier. Durabolin, the senior physicians know about that. Patient coming with bony pains, we have been giving this Durabolin injection and that is also that was for the osteoporosis. Androgen can influence bone health by binding to androgen receptor directly or to estrogen receptors indirectly via the aromatization to estrogen, and the several studies showed that androgen stimulates the proliferation of pre-osteoblast and differentiation of the osteoblast. Now, the association between testosterone level and the bone mineral density in females, a positive correlation between testosterone levels and lumbar bone mineral density in American female aged 40 to 60 years has been demonstrated. Now, what are the evidences regarding this? On the body fat and lean mass in obese men on a hypocaloric diet, a randomized controlled trial, and this shows that among the obese men, testosterone treatment augmented diet-induced loss of total fat and visceral fat mass and preserved lean mass in contrast to placebo-treated men who lost both lean and fat mass, and this is how we can prevent the sarcopenia in this population. Again, serum testosterone levels in the high physical activity group were significantly higher than those in the low activity group, and this effect was not observed between the groups based on the calorie restriction levels. So, physical activity is very, very important. Now, testosterone and aging, male testosterone production with age, you can see that the level gradually goes down, and there is testosterone deficiency as the age advances. Longitudinal studies in male aging studies have shown that serum testosterone level decline with age, and total testosterone level falls at an average of 1.6% per year, while free and bioavailable levels fall by 2 to 3% per year. And the reduction in free and bioavailable testosterone level is larger because aging is also associated with increase in the sex hormone binding globulin levels. And the changes in average serum testosterone level with aging mean that proportion of men fulfilling a biochemically defined diagnosis of hypogonadism increases with aging. 20% of the men aged over 60 have total testosterone level below the normal range, and the figure rises to 50% in those aged over 80. This is the mechanism of diabetes in men and the androgen deficiency, which is again very important. In metabolic syndrome, there is testosterone deficiency with aging as well. Through the beta cell dysfunction and the insulin resistance, we develop diabetes. And through the increased adiposity, again leading to all these metabolic disorders, and finally, if there is severe testosterone deficiency also, that also leads to diabetes progression. And it is a bidirectional modulation of beta cell function in male and female, and this is the most sexually dimorphic aspect of metabolic regulation to the bidirectional modulation of glucose homeostasis by testosterone in male and female, which you can see here in this diagram. Now, I think many of us recognize this gentleman, Dr. Paresh Tandona, who hails from India, but he is the professor and head of endocrinology at Buffalo University, USA. He has a lot of work on the hypogonadism and this subject, and the message is clear from him. All people with type 2 diabetes and or obesity should have their testosterone measured, but I don't know how many of us are really go for this. Low testosterone. Why low testosterone? Because the testes are not able to make enough testosterone, or the brain is not making enough luteinizing hormone which signals the testes to make testosterone. So both can result from infection, trauma, exposure to toxins like the chemotherapy or the genetic conditions. And the chronic illnesses like diabetes, obesity, anemia, and HIV infection, they are also linked to low testosterone levels. And certain medications like opioids, corticosteroids, and anabolic steroids can lead to low testosterone levels. Now, what are the clinical signs, symptoms, and conditions of low testosterone level? You can see that most specific signs, symptoms, there is reduced sexual desire and activity, decreased spontaneous erection and erectile dysfunction. That is again very common in diabetes because of many other factors and the pathophysiologies. Decreased testicular size, loss of pubic hair, reduced shaving requirement, increased body mass index, visceral obesity, height loss, low trauma fractures, reduced bone mineral density, and there are other more general signs and symptoms which you can see here. And the very many conditions commonly associated with low testosterone level and adult onset hypogonadism. They are type 2 diabetes, metabolic syndromes, osteoporosis, and stage renal disease, and patient on hemodialysis, HIV, history of infertility, cryptorchidism, pituitary disease, delayed puberty, and treatment with opioids and glucocorticoids. So we must assess while taking the history of the patient, and the symptoms also we must assess. Cardiovascular disease or coronary artery disease, men are at threefold increased risk of developing CAD as compared with women, and men often develop the disease a decade earlier than females. Men experience a gradual decline in testosterone level with increasing age, and there is a growing body of evidence suggesting that testosterone deficiency have a much stronger association with coronary artery disease. Now coming to the testosterone replacement therapy, which is again very, very important. And I don't know how many physicians undertake this. Aim of testosterone replacement therapy is to provide the development of and maintain the secondary sex characters and to improve the symptoms and signs due to testosterone deficiency in patients with androgen deficiency. And TRT has positive effect on secondary sex characters, sexual functions, muscle strength, physical function, mood, and bone density. And the biochemical goal is a treatment to keep testosterone levels at mid-normal range. When testosterone deficiency is suspected, a man should undergo a medical history and good physical examination by either his primary care physician or by a specialist. Blood tests to check the morning total testosterone level are typically performed twice to confirm the diagnosis. Early morning sample, at least 2 samples. Other blood or imaging tests may also be necessary. What does guidelines recommend? We take one guideline of the European Academy of Andrology given in 2020. Functional hypogonadism should be diagnosed only after exclusion of organic causes of hypogonadism. In addition to morning total testosterone, luteinizing hormone should be measured in all patients with suspected functional hypogonadism to differentiate between the primary and the secondary causes. Either measuring or calculating free testosterone in addition to total in patients with conditions that alter sex hormone binding globulin and when total testosterone concentrations are in the borderline range. Recommend lifestyle changes including physical exercise and weight reduction to overweight and obese men with functional hypogonadism, since weight loss may increase the testosterone concentrations, and suggest withdrawal or modification of drugs like opiates, anabolic steroids, glucocorticoids potentially interfering with T production when clinically permissible. Suggest the use of transdermal testosterone as the preferred preparation in the initiation of TRT for functional hypogonadism, gonadotropin therapy in men with secondary hypogonadism only when fertility is desired. TRT in hypogonadal men with sexual or erectile dysfunction to improve libido, erectile function, and sexual satisfaction. But look at these mentioned below, recommended against testosterone replacement therapy, and which is very, very important. Weight reduction in obese men is not an indication for this, and this is against TRT. Improve glycometabolic control in men and with type 2 diabetes and or metabolic syndrome. Sole purpose of reducing fracture risk in hypogonadal men with high fracture risk is not the indication for TRT. Routinely prescribing testosterone to men more than 65 years as an anti-aging therapy, and to frail men to improve exercise capacity or physical function, in aging men to improve cognitive function, and in men with untreated prostate or breast cancer. So these are the important factors we must always consider before we consider for the TRT. On treatment, serum total T concentration should be measured at each clinic visit to ensure that average total T concentration achieve the targeted mid-normal range for young men. Performing digital rectal examination and to check for PSA to look for any hyperplasia of the prostate, especially the prostatic carcinoma screening should be done, and further evaluation by the urologist. PSA. If PSA is more than 4 nanogram at any time, and detection of a prostatic abnormality on DRE or a substantial worsening of the LUTS. So patient should be followed up properly. Recommended measuring the hematocrit, which is again very important, 3 to 6 months after initiation of TRT and then annually. And if the hematocrit is more than 54%, TRT should be discontinued until hematocrit decreases to a safe level. Evaluate the patient for hypoxia and sleep apnea. Consider reinitiating TRT with a reduced dose. Now, this is the treatment algorithm. Patients meet criteria for testosterone deficiency and is a candidate for testosterone therapy. CVD risk assessment at high risk for cardiovascular events should be referred for further evaluation. Discuss the therapeutic modalities including lifestyle changes, which is again very important, and weight loss is one important factor which should always be considered. Then the exogenous testosterone in the form of gel or cream or patch or buccal or intramuscular subcutaneous pellets or the nasal spray. And then there are alternative studies also measure on treatment testosterone levels to look for how long we have to go for the therapy. So these are the diagnosis for guidelines for diagnosis of treatment of LOH. Various associations have given many guidelines for that. Now, so 1 minute more. Testosterone therapy is only recommended for hypogonadism patients. Boosting testosterone is not approved by the US Food and Drug FDA to help improve strength, athletic performance, physical appearance, or to treat or prevent problems associated with aging. The various preparations are available. Even in our country, preparations are available in the form injection, gel, solutions, patches, buccal tablets, pellets, nasal zen, and these are the various routes of administration of all these. And these are FDA approved testosterone products which are available outside, and in our country also these products are available by different names. But my suggestion is that TRT should be given by the specialist, not by the healthcare provider at the initial levels. Because side effects are very important. Erythrocytosis, acne, sleep apnea, possible prostate and or breast enlargement. There are no firm scientific evidence that long-term testosterone replacement is associated with either prostate cancer or cardiovascular events. But we have to be careful. Prostatic cells are stimulated. FDA requires patients are made aware that the possibility of cardiovascular event may exist during the treatment. So cardiovascular disease, as I told you, erythrocytosis, then fluid retention, abnormal digital rectal examination to look for the prostate, acne patients, and hepatotoxicity. But liver function tests are unnecessary if you are treating the patient with gel, pellet, or the IM preparation. Then look for BPH, look for prostatic cancer, gynecomastia, or the breast cancer. The contraindication, thromboembolic disorder, prostate or breast cancer or suspected elevated PSA levels, enlarged prostate causing difficulty with urination, cardiovascular event within the last 6 months, high number of red blood cells, planning of to have children, and untreated sleep apnea. So these are the various contraindications. These are side effects which I have already narrated to you: the cardiovascular, hepatotoxicity, gynecomastia, infertility, and potential aggression associated with testosterone administration. So to conclude, testosterone is so much more than reputation would suggest. Men and women need the proper amount of testosterone to develop and function normally. Checking testosterone level is as easy as having a blood test. Difficult part is interpreting the result. Levels are over the course of the day. Single low level may be meaningless in the absence of symptoms, especially if it was normal at another time. And we need more research to know when to measure testosterone, how best to respond to the result, and when it's worthwhile to accept the risk of treatment. So to summarize, testosterone level decrease with advancing age. Replacement therapy recommended only for hypogonadism, primary or age related. Various forms of testosterone are available to be given. Risk associated, I have already told you, to be monitored, and TRT contraction in certain conditions. So before I thank you all, I invite you all for this 52nd annual conference of RSSDI at New Delhi in Yashobhumi, which is the biggest convention and exhibition center as of today in South Asia. It is from 14th to 17th November. And myself being the organizing secretary, I invite you all, please register at the earliest possible. And most of the pharma companies are involved into it. So you can approach any of the pharma company. So with that, I thank you everyone, thanks chairpersons, and my special thanks to the organizing committee and my friend Professor Jain Panda for giving me this opportunity this morning to interact with you. Thank you very much.
Thank you. Thank you, sir, for your excellent presentation. Any questions from the floor?
Yes, sir.
So thank you, Professor Sharma. It's a very bright forenoon, excellent weather. Invited as you are the organizing secretary. And you have made all the clinicians probably sexually active also by giving such a talk on testosterone. Now people today, nowadays we are finding, they have become very conscious after the age of 60 and asking. Sometimes his wife asks, sir, my husband has no timetable. Very difficult to understand. When you call the husband, he says, yes, sir, she is correct. What correct? Because probably she has no desired sexual activity, so the partner is dissatisfied. And we do not know also the clinicians, we do not know what is their status, whether they will be more active in their professional life if their testosterone levels are maintained at a normal level or not. So with hypogonadism at the age of 60, after doing a testosterone test, and also as you said about the contraindications, should we prescribe in low doses to all such individuals, even though those who are not diabetic also?
Sir, management of any problem, or we can say any disease of the patient should have a holistic approach. First and foremost is a good clinical history where we evaluate all aspects. What is the mental status of the person? What is the level of anxiety? What is the level of depression? Is he suffering for any other comorbid condition? Is he having metabolic diseases? What is the status of diabetes? Is diabetes under control? Is the patient having erectile dysfunction because of diabetes and because of the autonomic nervous system? So, it is not only the testosterone level which is responsible. Patient's approach and investigation we have a holistic approach, good clinical history, talk to the family, talk to the couple, and then evaluate. Take a good history, take good examination, evaluate all aspects, and also keep testosterone level at one point in evaluation, and accordingly you decide. First see if there is any contraindication or not, and then a good follow-up is required. Thank you, sir. Thank you very much.
Thank you, sir, for.
Yes, sir.
Sir, in case of elderly male members having prostatic carcinoma, even the surgeons are advised and go for orchidectomy. And we want to diminish the level of testosterone for primary treatment status. So in that situation, we should not be worried for sexual stimulation and testosterone.
Yes, sir, because we have to weigh which is important. The health of the person is important from that point of view. Prostatic carcinoma, we have to treat the prostatic carcinoma, and then it becomes secondary. Thank you.
Okay, we conclude the session here. Thank you.
Thank you, sir.
I request the faculty and the chairpersons to kindly go to the podium for memento, and we'll move on to the next session. The chairpersons for the next sessions are Professor Dr. Pradeep Kumar Behra, who is a professor of medicine in KIMS, Dr. Apurva Ranjan Jaina is a consultant diabetologist of SCG Panda Cancer Hospital, Bhubaneswar, and Dr. Utkal Kishore Khadanga is a consultant diabetologist in Care Hospital, Bhubaneswar. Over to you.
So, moving to the second session, we have 3 talks in this session. And the first talk is regarding diabetes in elderly. So, aging is a normal anticipated phenomena to anybody who is born. But with aging, lot of anatomical and physiological changes occurs. So, so treating elderly diabetics is to consider them in a special category, and this is a very useful topic. And for this topic, I invite Professor Surendranath Swai sir. Sir is a well-known name in many academic bodies in the state and as well as in the national level. Sir is presently Chairman API ODISHA branch and Chairman Clinico-Cardiodiabetes Association of India ODISHA branch. Sir was ex-chairman RSSDI ODISHA. Sir is member of the Advisory Council of ACP India. Sir, I invite you for your talk. Now over to you, sir.
Thank you for your introduction. My topic today is diabetes in elderly. Because most people here are elderly because the youngsters are sleeping and are not interested in academics. So only elderly people are listening, and most people also have diabetes. So diabetes in elderly is very, very important nowadays. So you know that the diagnostic criteria that you know everybody, that what is the normal and what is the pre-diabetes. In fasting 100 and 2 RPG 140, A1C less than 5.5, and pre-diabetes impaired fasting glucose 100 to 125, and IGT more than 140 and 110 99 and 5.5 to 6.4 HbA1c in for screening for pre-diabetes. And the diabetes fasting is more than 126, and 2 RPG more than 200, and random is more than 200, and the HbA1c more than 6.5. So all these things you know. The next is what is the prevalence of diabetes in India. According to Indian Council of Medical Research, a national diabetes study, that 63 million people they found, and this set to increase over 100 million in 2030. The majority of people with diabetes, more than 90% have type 2 diabetes. So this is a figure of how it is increasing in the world, and the prevalence in India. Sri Lanka is behind, and Pakistan and Afghanistan is nearing to us, and this is India scenario. What are the and the epidemiology? The more than 20% of patients of 65 above 65 are diabetic. 10% diabetes cases are diagnosed after the age of 65. So no long-term studies in geriatric population has been done. Uncomplicated healthy geriatric patients may adhere to the same goal and therapy recommendations as younger patients. Because old people all are not old. I am not old, I am 70. I am young old. So similarly, other people are the mid-old, and some are old and old, who are around 70, 80 or like that. It is depending upon the structure, physical activity, mental conditions, environment, and the finance, and in which environment you are, whether you are alone, whether you have finance, whether everything. You have children and you are in a combined family, or you are only nuclear and your wife is not there. So naturally all these factors are falling on the diabetic elderly. And how to treat? The start low and go slow, because he is an elderly, respected person. Frail patients at risk for hypoglycemia, those with functional or cognitive impairment, and those with life expectancy less than 5 years may have less intensive goals. So go slow for them. They have less than 5 years living, very old, around 80, 85. So in that case, fasting blood sugar should not be 100. It can be go up to 130, 140, 150. And HbA1c not 6.5, below that. It should be 7 to 8. Otherwise, they will go into hypoglycemia. And this pathogenesis of type 2 diabetes, everybody knows, genetic predisposition, obesity, lifestyle, and this all you know, this ominous octet, you know the symptoms of diabetes that everybody knows. And what does hyperglycemia cause? It can cause delirium. That can cause mood swings and irrationality. There may be lack of appetite and the sleep disturbances is a common factor in elderly. And there is an increased risk for diabetic ketoacidosis, hyperglycemic hyperosmolar state. There is impairs cognitive ability because the old man sitting at home, nobody is talking with him, the son and daughter, and his son-in-law or the daughter-in-law going for their job from 8 to 8, 8 a.m. to 8 p.m., and nobody at home. The elderly lady is also busy in cooking and everything, so nobody is there to talk. So if somebody is not talking, you will have impairment of cognitive ability. So you must talk, you must discuss. Because in most of the places, our colleagues be silent. Don't want to talk with the colleague who is sitting beside while taking food or moving or sitting in this hall. Nobody is talking with each other. Maybe two factors. One is ego. Second thing, they don't want to mix with other people, setting his ego. It's the I'm important. Let him speak fast. Why I will talk with him? So that is not very good in the sense of prevailing cognitive disability will occur fast to them. So be social, be communicative, go to the different clubs and parks and move with societies. And there is in elderly, there is reduced energy, impairment of memory, not able to remember or recognize easily, decreased wound healing, increased risk of HSS on diabetic ketosis, increases urine output and impact of incontinence and dehydration, and increased risk of UTI because of the prostate enlargement, impairs immune system because of the elderly age. And hypoglycemia is very common. Aging increases the risk of hypoglycemia because reduced hormonal counter regulation. Renal and hepatic changes, there is decreased function of the renal and hepatic organs, that is hydration status is low. Nobody is giving the water. He has to pick up water. Therefore, there is less of intake of water, inadequate or irregular nutrition. Nobody is taking care. You have to ask for food, and nobody is there at home also. You may have to cook. Decreased intestinal digestion, and there is autonomic neuropathy. And there is a polypharmacy because of so many comorbid conditions, and use of alcohol and other sedating meds if he is habituated earlier. And this can cause arrhythmia, increased risk of falls. Signs and symptoms may be masked by comorbidities like Parkinson's, impairs concentration and cognition. Cognition impairs reaction time. So cases of mistaken identity, in a case of aged and in case of diabetes, they look similar. A aged person needs a glass, but a diabetic has a blurred vision. He's thinking he's old. His son will tell he's old, but he has diabetes. He has blood vision. So you have to take care of his blood sugar. More frequent urination. Elderly man, he is going for urination, maybe prostate enlargement, but there is polyuria or nocturia because of diabetes. Can't go do things like you did when you were 20. When you were young, you were able to do, but elderly, how is he becoming old? It may be due to fatigue of diabetes, not because of old age. And there may be MI and CVA, 2 times more common in diabetic than in non-diabetics. Atherosclerosis is common in elderly. High blood pressure may be common in both, in diabetic or non-diabetic. Changes in gait. He is an elderly person, therefore he is having the gait. But that may be neuropathy because of diabetes. So find out. Restlessness and confusion and slower cognition because of his elderly age. The son is telling. But maybe that all due to diabetes, uncontrolled. And maybe blood pressure is also not controlled. The blood sugar is not controlled. It may be high, it may be low. So, poor diabetic control exacerbates the aging process. Poor diabetes control causes age-related disease to develop earlier. Poor diabetes control makes comorbid condition worse and harder to manage. Diabetes assessment in older adult, how you will assess. Physical assessment, you see the mobility, whether it is physically active or not, and see the nutritional assessment, whether there is sarcopenia. Neurological assessment you have to do, and psychological assessment, whether in good health, healthy mental conditions or not. And eye, You must examine. Higher rates of cataracts are there in elderly. Glaucoma and macular degeneration may be due to diabetes, not due to elderly persons. Auditory, the auditory signs, and there is a dysfunction, is not having a receptive deafness. So you have to do audiometry and see, and so to an ENT specialist. Renal, thickening of basement membrane, so that is reduced renal function. Immune system is low. There may be viral infections like flu, herpes zoster, and also they are prone for cancer also. Cardiovascular system, reduction in CVD risk factors may have greatest impact on morbidity and mortality, because there is hypertension, there is CAD, there is dyslipidemia, increase of CVA and myocardial infarction, increased heart rate in response to exercise is not there. Thickening of basement cell membrane in kidneys. 50% newly diagnosed people with type 2 diabetes have cardiovascular disease. And there may be history of injury and falls. Frailty is one of the factors because of the nutritional loss, sarcopenia, and this is autonomic neuropathy or polyneuropathy. And there may be joint disease. There is a osteopenia or osteoporosis and decreased aerobic capacity. There is lean body mass is low. The fat mass is also sometimes high because of the no exercise and sitting idle at home, and decreased activity because the son is telling, don't go outside, you are old. And retinopathy, you have to examine in all cases of elderly, dilated eye examination, high risk symptoms of eye disease, retinopathy, glaucoma, cataracts, etc. You must see, and see the BP also, and every year you must examine, and every 2 years you must do ophthalmoscopic examination. And food screening, see the skin integrity, loss of protective sensations, and early detection of neuropathy, which will help you to prevent a foot ulcer, decrease perfusion, you see the Doppler, and bone deformity, do the DEXA scan and all that. So nephropathy also, see the albuminuria, creatinine, and GFR. And preferences and lifelong habits for nutritional habits, meal planning, give morning breakfast, lunch, evening snacks, at night. Most people take lunch and dinner, and sometimes skip the breakfast in the evening. And most people do not take in the evening, that's the thing. So lifestyle changes should be there, and mobility, they must move, they must go into the park, maybe that half an hour, 15 minutes, 10 minutes, or 30 minutes, like that, as per his capacity. And dentition, you must check up, because if there is no good dentition, digestion will be improper. So to the dentist, high risk considerations and malnutrition, see the vitamin deficiencies, and depression and cognitive impairment one must assess, and hydration status, alcohol abuse or should be stopped, and the smoking should be cessation should be there. And some people take the Ramdev medicines or any Ayurvedic medicines to make them stronger. So, but to avoid that, because maybe impurity may be there that can be detrimental to his health. And see the system of gastroparesis because of diabetes is having a loss of appetite, decreased digestion and absorption, and whether there is a cognitive impairment, and do a mini-mental status examination, and check for B12, thyroid hormone, vitamin D, neuroimaging, depression screening, and blood glucose control, and autonomic and peripheral neuropathy, see the heart conditions, do an ECG echo, and standing BP, etc., incontinence, sexual function, you must find out protective sensations, which is there or not, hypoglycemia, unawareness, because of autonomic neuropathy, find out, and body temperature regulation also should be exhibited, and reduced ability to sense thirst, smell, and taste should be assessed. And the psychological assessment, the depression, loss of companions, because mostly the elderly people are without their wife, or the wife is without a husband. So that is one of the major cause of depression in case of elderly. And change in family role, because of the previously the joint family was there. So the elderly man is talking with the small grandchildren, which is not there nowadays. They are in Bangalore and you are at Bhubaneswar. So naturally you are alone. So the change in family role is there. Sometimes the wife is going for the pregnancy of the child, and the husband is alone here also. It is very difficult to manage the social functions. Now it is in a very difficult stage, and the depression and the problem of self-assessment, and caring is at the lower age. And other areas of assessment, the comorbidities, because the polypharmacy, you have to take so many diseases like that, hypertension, diabetes, dyslipidemia, prostate enlargement, and the fatty liver. And so all these things, one has to take a hypothyroidism, etc. Diabetes and medications appropriate, whether he's taking regularly or medicines one must supervise, and drug interactions, whether he's taking everything at a time or not. Ability to administer medications has to be taken care of, or somebody must write in the morning is this thing and daytime is this thing. You must, the children should make a chart when to take, how to take, whether before food or after food, either the patient is not unable to see the label of the drug also. Sometimes by mistake somebody is telephoning, I have taken 2 medicines of blood pressure medicine. What will happen? That's the thing. Or I have taken 2 diabetic medicines at a time. So this, because he has failed in memory, whether I have taken or not, then again he is taking again. So that thing, who will take care? Either the wife or the children, but nobody is there. And safety and finances, you have to your menials in the home, and sometimes you have heard that one person, lady justice was there at home, and the driver strangled that fellow and took away all the money. So this, you must be safe at home. You must see that menials do not attack you. You should be safe. And treatment recommendations is glycemic control. Hypertension should be controlled. Dyslipidemia should be there, should be taken care of. And tobacco cessation, eye care, food care, nephropathy, and diabetes self-management training has to be done. And when and how to prioritize interventions to take care, and comorbidities should be taken adequate care, and frequent checkups with the different specialists has to be taken. And complications to be attended fast, and risk of benefit and recommendation, healthy elderly people with diabetes should be treated achieved with same glycemic blood pressure and lipid targets as younger people. There is no difference, nearly no difference. But if it is frail elderly, we have to reduce the doses, increase the HbA1c to even 7 to 8, and sometimes also 8.5. And the fasting and and postprandial is also, postprandial can be not 140, it may be 180, and the fasting can be not 100, it may be 130, 140, like that. So known by strict control of frail elderly is not mandatory, because that will land in hypoglycemia, and each stage of hypoglycemia will land you in dementia. So the more frequent you are having hypoglycemia, more early you will be demented. You will not senile dementia will come early. And cognitive impairment, I have told, avoid hypoglycemia, and hypertensive treatment must be checked regularly, and aerobic exercise, minimum 30 minutes, 10 minutes, 15 minutes, or a resistance exercise also minimum 15 minutes. That is recommended. That is 150 minutes in a week, but that is not for mandatory for everybody. But the elderly person can do 20 minutes also, no problem. And this is the different drugs, and the safest is insulin can be given, but in a reduced doses. See that there will be no hypoglycemia, and the insulin pen is better rather than the mixing, and clock drawing test to know his mental status, and this is the A, and consider the HbA1c, and non-insulin agents, the gliptins and glipogins are better, because the comorbid conditions of cardiorenal benefits SGA2, and the gliptins are weight neutral and no hypoglycemia, so they see that. And metformin can be given on, because non-hypoglycemic, so those drugs like glimepiride, etc., sulfonylurea should be avoided because of the hypoglycemia. So time is up, is so you must take care. I have told everything. So this you must take care of the elderly, everybody. Every physician here, they are elderly, but if the parents are there, they are more elder. You must take care. Who will take care? So this is the social responsibility, individual responsibility to take care of yourself. Being you are managing yourself, although you are elderly, you are not old, you can take care of yourself. And if there is any other parent, other family members, they must take care. So this is a social responsibility of taking care of the elderly. and managing diabetes as a whole. Thank you very much.
Thank you, sir, for such a nice deliberation. So, elderly, managing diabetes in elderly is a challenge. Many things has to be considered, including their altered pharmacokinetics, their structural, functional impairment, multiple comorbidities, social issues, financial issues. So nicely covered, sir, in this topic. Very useful to all the practicing physicians. Thank you, sir. Any question from the floor? I'll invite.
And some other supplements like vitamin D, say after intervals, say pulse doses should be given not to be affected by all these deficiencies, keeping them healthy all the time.
Yes, you are 100% right. You must take antioxidants, vitamins, because they are all deficient, because they're nutritionally deficient. Therefore, take vitamin D, but do 25-hydroxy D intermittently, because not that everybody should take vitamin D regularly as prescribed. They must do intermittent 25-hydroxy test so that you will not land into hypervitaminosis D, because it's a fat-soluble vitamin. Second thing, and calcium you have to take, otherwise osteopenia and osteoporosis will take its role, and vitamin B12 also required for the mental conditions, and all B complex should be taken, and multivitamins, as like you have told, it is all mandatory requirement.
Thank you.
ফটোটা নিয়ে যাবি ক্যামেরাতে ফটো উঠে দিও
So, if no questions from the floor.
So thank you very much for your patient hearing. Thank you very much.
Next speaker is Dr. Purvi Chawla, and she needs no introduction. She is a very famous orator. Though a little bit about her, she practices at Mumbai. She has got Lena Diabetes Care and Diabetes and Beyond Clinic, and she is a co and sub-instructor of the Global National Clinical Trials at BSCAS Mumbai, president of Santa Cruz Medical Association, and SCOPE Certified World School of Obesity Management of Obesity Program. Over to you.
Thank you. Jai Jagannath, very, very honored and pleased to be here. Thank you, Dr. Jayant Panda, for having me here on this prestigious platform with all of you. And thank you for that kind introduction. So again, remission of type 2 diabetes, is it really achievable? And I think a lot is said and done about it, but we constantly need to renew our fundamentals in this aspect, because there are a lot of ads and a lot of hoax programs going on with respect to remission and reversal. So thank you for this opportunity to interact on this particular topic. First of all, I think just a quick reminder that overweight, obesity is definitely established as a very serious disease and also a morbidity along with type 2 diabetes, because they share very key pathophysiological pathways, right? And weight loss is definitely again established in literature that it is associated with metabolic improvement in type 2 diabetes, and also more than 15% weight loss is actually disease modifying. So with that statement itself, let me dive into this talk. The fundamental goals of remission are not only improved glycemic control but also weight loss, because of the improvement in just not the glycemic control but also the comorbidities associated with diabetes. So basically, it is weight loss that drives remission. And of course, cure, we should not talk about cure for diabetes because there is always a potential for reoccurrence, and that is why, and which is also well documented, and that is why the exact criteria are still debated, but we cannot say that diabetes is curable. Amongst all the initial definitions for remission, partial remission was when an individual with diabetes achieved an HbA1c of 6.5 or lower, or fasting plasma glucose between 100 and 125 milligrams per dl, and off all the diabetes medications for at least a year. And then complete was when this level was even lower, HbA1c of less than 5.6, and fasting glucose of less than 100, and then prolonged remission was when all these parameters were sustained for over 5 years or more. However, the ADA came up with this consensus which has been agreed upon by many associations across the world, and this talks about defining remission as return of HbA1c to 6.5 or less than that, which either occurs spontaneously or because of an intervention and persists for at least 3 months without any glucose lowering medications. But today we are in an era of SGLT2 inhibitors and GLP-1 receptor agonists, and we question if the patient is on these drugs because of other reasons of cardiac or renal reasons, can we call it remission? I mean, if they are still on these drugs. And of course, metformin from the glycemic medications list can be removed because again, it has such a wide application beyond diabetes as well. So again, these are some things to ponder upon. And no talk of remission can be complete before we talk about the twin cycle hypothesis. This was the famous 2018 Roy Taylor talk and publication. So just very quickly, when there is excess of positive energy intake or excess carbohydrates being exposed in the liver, then all these excess carbohydrates are converted to triglycerides, and this excess liver fat is again concentrated in the liver preferentially because of already existing insulin resistance and is impacted by the endogenous insulin also. And this preferentially will help the person with insulin resistance to accumulate more liver fat than anybody else. This increased liver fat will not only augment the liver insulin resistance, but also increase the insulin resistance across the different organs, because when the subcutaneous fat is overwhelmed, it again goes and sits in the liver. Not only, and this leads to one cycle of increased insulin resistance, hyperinsulinemia, and plasma glucose increase, which is hyperglycemia. So that's one tract. And the other bad thing that happens is that extra lipid is exported to other organs from the liver in VLDL triacylglycerol form, and this is again preferentially taken up by the pancreas. In fact, even a gram of fat in the pancreas can lead to type 2 diabetes. So this excess fat in the pancreas is what impairs the beta cell functioning and causes that impaired insulin secretion and eventually clinically manifesting as type 2 diabetes. So this cycle is really important to understand so that we can know what we need to target or where we need to intervene in order to cause remission of diabetes. So again, type 2 diabetes, you can see increased liver fat, increased fat from the liver exported with as VLDL particles to the pancreas, and then reduction in beta cell function. However, in remission, what happens is that liver fat decreases, causing a further decrease in the export to the pancreas, and again extracting that fat from the pancreas and restoring beta cell function. However, weight gain and re-emergence of diabetes, it can come up when the liver-derived plasma triglycerides and reaccumulation of fat occurs within the pancreas. So what have we learned? Well, can long-standing type 2 diabetes go in remission? Well, the initial studies have not shown that, but there are exceptions to the same. Can diabetes with normal BMI go into remission? There's a very interesting retune study which also has proven that yes, it can be difficult, but normal weight or normal BMI people can have fatty liver, which can be targeted as a therapeutic target, and we can cause remission in these. So again, key features with those who will benefit from weight loss and go towards remission are those with presence of central obesity, increased waist circumference, acanthosis nigricans indicative of insulin resistance, multiple skin tags, hypertension, hypertriglyceridemia, mast cell, and laboratory evidence of hyperinsulinemia. So all these help us select patients for remission. These are not just factors I've listed here, but these are the people who will benefit or can aim at remission. Will diabetes come back? Yes, most certainly it will come back if there is regain of weight or loss of the dietary restrictions or exercise. And what is the best advice to give prevent weight regain? Well, eucaloric diet with lots of exercise. So whom does reversal work for? Like I said, HbA1c probably not very high and blood sugars not overtly elevated at baseline, because that would be an ethical concern also. If the person is in glucotoxicity and we try to aim at reversal, that would be more harm done than good. So, and again, it has been seen that probably men are more favorable for remission as compared to women, because they can achieve greater weight loss, higher body weight, high C-peptide or insulin secretion, and who do not take insulin, shorter duration of diabetes, say 6 years or less as proven in the trials, and who are motivated and enthusiastic. So again, what is the evidence for remission? We have at least 4 major pathways for remission. One is bariatric surgery, low caloric diets and low carbohydrate diets, and also partly physical activity. Bariatric surgery we know has consistently shown to dramatically impact weight loss and definitely remitting diabetes in at least 80% of the patients in the short term, and this is attributable to the change in the gut microbiota, making it more healthy and more conducive to maintaining that weight loss, and also to the changes in the gut hormones or the GLP-1, PYY, oxyntomodulin and other such incretin hormones. In terms of the complete and partial remission rates with bariatric surgery, let me quote some studies here. The 5-year follow-up studies, in that we have the sleeve pass in 240 patients, where they compared the laparoscopic sleeve gastrectomy with Roux-en-Y gastric bypass, and they saw 37% remission in the former and 45% remission in the latter. The Stampede trial further had one more arm with intensive medical treatment as well, but that performed dismal because only 5% remission was seen in these particular patients who were obese, had type 2 diabetes, but were only exposed to intensive medical treatment. But let's remember, in those days we did not have the newer GLP-1 or the triple agonists or the co-agonists that we have in today's time and age. The 10-year follow-up studies again showed that 10-year remission rate of 83% was also noted in one of the trials, and the SOS, which is again a very popular trial with Roux-en-Y gastric bypass evaluated, found that 2-year remission rate was 72% and 10-year at 36%. Now we come to the low caloric diets, and Look Ahead trial is one of the really landmark trials, and even though it was conducted in approximately 5,000 patients and had 2 arms where they compared intensive lifestyle intervention versus just diabetes education and support, and they found that remission rates were 11.5% at 1 year and gradually came down to 7.3% at 4 years, but was not that dismal. However, the primary endpoint of this trial, which was the reduction in cardiovascular outcome, this was not met. So as such, it's a failed trial, but very important lessons came out of it in terms of remission was maintained in those who were able to maintain weight loss. Exercise was enjoyed by these participants who were guided with the same, quality of life improved, and so on and so forth. But let's understand that in the Stampede trial with the intensive medical treatment, again there was only 5% remission seen there as well. Then comes the 2015-17 era, where at least 3 trials looked at short-term remission, and again they found not very high rates, 5 to 6% remission. Coming to the next set of studies, 2011 had the initial 8-week study where they compared a very low caloric diet, 600 calories given, but 25% had early recurrence. 2016, they conducted a larger and a longer trial where again 8 weeks of very low caloric diet with modified reintroduction of food was given, and then 6 months of weight maintenance. However, and they found that 40% of those who were initially responding were still in remission. So of course the evidence was evolving, but nothing very dramatic about these trials. Now 2018 was a game changer because that's where the direct trial came. Again, merits of the trial, it was conducted in the primary care setting, community-based, cluster randomized. And they included patients of type 2 diabetes with less than 6 years duration who were not on insulin and had a BMI above 27 kilogram per meter square. 306 patients were randomized to receive either standard care or very low caloric diet, almost 850 calories per day for 3 to 5 months to cause weight loss. And they defined diabetes remission as HbA1c less than 6.5% with no medications. There was stepwise food reintroduction, and they found that half the patients, 46% of the initial participants had diabetes remission at year 1 and 36 at year 2, which is really much more than any of the previous trials had ever shown. So definitely these went into long-term weight maintenance. So just quickly eyeballing the results, you can see on the first left panel that at least 1/4 of the participants lost more than 15% of their body weight at year 1, and half of them persisted with that weight loss at year 2. You can see the right top graph, again remission in half of the patients, and even 1/3 maintained that remission even at year 2. And the bottom panel is interesting with 5 to 10 kilo, more than 5 kilos or 5 to 10 kilos, 10 to 15 kilograms, and then more than 15 kilograms. And you can see that 86% have remission if they lost more than 15 kilograms of their baseline body weight. So these are some fantastic results from the direct trial which made everybody think that probably remission can be achieved. Now, year 2 studies, year 2 follow-up of the direct program showed that more than 1/3 of people with type 2 diabetes maintained that remission at year 2, and this was because of sustained weight loss. So the bottom line was that in those who were in remission after 1 year and who stayed in remission had lost a greater amount of weight, more than 15.5 kilograms, and those as compared to those who did not stay in remission. So that 15 kilograms was the magic number that came from the direct trial. Further analysis also showed that in those who responded, it was the liver fat, VLDL levels, and the pancreatic fat which was documented as reduced. And in fact, even the cellular level data shows us that as compared to the last column, which is the normal pancreatic volume or the pancreatic raggedness, which is the lowest in normal individuals, and maximal insulin secretion, all that was gradually achieved in these patients who were on sustained weight loss programs. Now we have, this year they released the direct trial data at 5 years, and this is the longest ever. They found that in the extension participants who lost further 6.1 kilograms, 13% were in remission. So amongst all the landmark trials, you can see in yellow that everywhere there was weight loss, significant weight loss of 8.5%, 9% to 12% or 12 kilos, there is associated remission at 12 months seen. And then we know that there is remission sustained as per the direct trial. I'm going to take 2 minutes more. Coming to low carbohydrate diets, we know that, so this is just summarizing what we have with low caloric diets, don't get confused. Again, we know that the problems with low caloric diet are always malnutrition or caloric restriction leading to vitamin deficiencies or micronutrient deficiencies, and that should be kept in mind when these patients are being followed. Low carbohydrate diets again have been seen as very, very helpful in improving glycemic control, and those with the lowest carbohydrate intake had the greatest glycemic control and greatest medication reduction as well. Physical activity, although physical activity is great for health, exercise is not associated with any weight loss. However, for weight maintenance and to reduce the loss of muscle mass or even sarcopenia, exercise is highly inculcated in these individuals. So in general, the non-responders are, even with decreased liver fat and decrease in the pancreatic fat, there are some who still do not respond that well, and that's because of the intrinsic beta cell ability not to recover. So there is a genetic component as well. So as compared to all the, so this meta-analysis is important, and very quickly, because it compares the metabolic surgery output with the intensive lifestyle management, and it shows that basically as compared to medical treatment, the surgical treatments are definitely associated with more intense remission and more sustained remission of diabetes. The RETUNE study is another very important study that came only 2 years ago, wherein Roy Taylor's group took very healthy, they took type 2 diabetes individuals with a normal BMI of less than 23, and they were still able to get remission in these patients, giving us the thought that basically it's a personal threshold of fat which has to be crossed in order to cause diabetes remission. So because it is not standard of care, we don't offer it to our patients, but keeping those factors in mind, you can select the correct patient for type 2 diabetes for remission. And those who manage to keep the weight off will definitely keep their diabetes remitted. In the Indian scenario, even patients with longer duration and on insulin therapy have been shown to come down to the lowest level of medication requirement or even none, and they have maintained that remission for a long time. Also, 15 kilograms intentional weight loss normalizes the life expectancy, which is dramatically reduced for somebody with diabetes. So weight loss is the way, and weight loss in type 2 diabetes is akin to that of chemotherapy for cancer patients. Complications I already spoke about. Regular screening of not only HbA1c and sugar levels, but also for complications associated with diabetes is encouraged even after they have remitted, so that we do not miss and we do not get any patients with florid complications. So is it achievable? Absolutely. Overweight and obesity must be targeted with prioritizing those who already have pre-diabetes or diabetes, And weight loss for remission is really important, as important and equivalent to chemotherapy for cancer. And this remission word also comes from nephrology and oncology, where a potential, I mean, we know that the patient is doing really well in remission, but there is a potential for exacerbation or reoccurrence. Thus, we must support all our patients, but the key word is identifying the correct patients for remission. Thank you very much for this fantastic opportunity.
Thank you, ma'am. In this pandemic of diabetes, you have given some positive hopes. What's like remission? So everybody should counsel all the patients to follow these principles of weight loss, and we can have like the theme can be achieved like the diabetes in India. Thank you, ma'am, for the excellent talk.
Thank you so much. Thanks.
And there is just comment about Pubi's talk. Actually, this is a global question. Everybody wants to know whether it's a treatable condition, whether it's a reversible condition, whether remission is possible. So by talking this, you have talked the theme of the conference. Let's de-diabetes India. We are she is in the team, national team, which plans for a diabetes-free India by 2030, and our white paper is ready from the Diabetes India, and Dr. Purvi Chawla is part of it. So what she has told very nicely regarding the lifestyle modification and what we should understand regarding the remission, reversal, and a possibility of controlling your diabetes without medications. And not only that, there are papers, there are work in the field, and that we have to talk to our patient that such a possibility exists, because in real life the lifestyle things are very difficult to impose upon. Such a thing exists in the diabetes management, and by a aggressive lifestyle and what weight reduction and the lifestyle measures is suggested, by acquiring that, you definitely have an advantage over the people who are not adopting to the lifestyle. She has come all the way from Mumbai, and they have very a global event at the end of this month. The DRS is hosting diabetes prevention program. I wish that all of you will be part of that. Give a big hand for Dr. Purvi Chawla.
Sir, indeed an honor. Thank you so much. I'm humbled, and really those kind words coming from you, I couldn't have asked for anything more. Thank you so much.
Thank you, Purvi.
I request all the speakers and the chairpersons to move to the podium for memento distribution, and please take. For the next session, the chairpersons are Dr. Shambhu Datta from Vizag, who is a colonel in Indian Navy, and Dr. Eshen Kara, a consultant diabetologist from Raurkela. Over to you, sir.
Morning, all the delegates and all my seniors and friends. Today, now I'll be introducing one of the most prominent person here, who is also organizing chairman for this prestigious RSSDI Odisha, and he is none other than Professor Dr. Jayant Panda. He is professor and ex-head of the Department of Medicine of the most prestigious college, not only in Odisha, in India, that is SC Medical College. He is also a senior consultant in diabetes, metabolic and critical care medicine. He is also holding the appointment of Vice Dean, the prestigious ICP, Vice President of American College of Physicians, and he is also President-elect RSSDI 24-25, IMA 25-26 of Odisha, and also He is currently the chairman of this particular conference, and he has published many national and international talks, and any words about him will actually fall short, because I know him. He's my batchmate also as undergraduate, and I don't have much words, but because of him, actually most of the conference which I attended have become successful, and most of the state conference under his leadership I have seen they are of national level. So I always congratulate and pray Almighty Jagannath for giving more power and more blessings to him to continue such endeavor. Thank you.
Thank you. Thank you, Dr. Shambhu Datta sir. Thank you, Dr. Satyankar sir. It's a pleasure this morning again, and I'm happy that even on the last day, so many delegates are here and you are listening so carefully, and we have sessions in time. So it's a pleasure being with you all. And I thought that I'll take up a topic which is there in everybody's mind. That's vitamin D3. Before I start speaking, I'd like to know some facts from you. Lot of discussion for last 20 years regarding vitamin D3. Many feel that this is related to almost all metabolic, immunological, digestive, respiratory, cardiovascular, many diseases. And there is no speciality. Starting from infection to immunology, they work without vitamin D3 correlating their disease. The immunologists feel that this is greatest discovery after steroid in management of immunological conditions. And the metabolic physicians feel that it can be strongly associated with conditions like diabetes, obesity, hypertension, and dyslipidemia. So say communicable, say non-communicable, you all have used vitamin D3 during COVID time. Say infectious, every category of disease, they have an indication regarding vitamin D3. Lot of confusions. So it should be a debate always. It should be a session always. I thought of touching a newer part, that how many of you feel, before I speak, I'd like to know how many of you feel that vitamin D is related to diseases, and by correcting vitamin D3, you can help your patient getting relief from the disease itself. Please raise your hand. A good number of doctors feel, it's almost 70-80% people feel that it is relevant. The second question, all of us treat patients with vitamin D3. We give weekly tablets, we give injectables, we give 1,000, 2,000, 60,000 liquid granules, but after some time the vitamin D is continuing or stopped. Hardly we see people who achieve target. Maybe you can go 10, 20 millimole high, but at your normal level you hardly achieve the patient. So how many of you agree with me that the present treatment of the guidelines that we give 60,000 weekly for 12 weeks, then monthly, or maybe 3 monthly we are continuing for lifelong, and especially in Indians we see a very strong association of vitamin D3 deficiency along with metabolic diseases. In such situation, the present dosage regimen doesn't fit well to our patients. How many of you feel? Please raise your hand. Few. Maybe many are happy with the present regimen, but in my practice I see whatever I give, the achieving target is delayed and not satisfactory for us. So today, in next 10 minutes, I'll tell you the scenario and how should we go about. So it's newer innovations, newer preparations. There are many people who are working on this. All of us know that the rickets outbreak was there in the 17th century, and we read rickets very well wrote short notes and long questions. I have contributed to the rickets chapter in API textbook of medicine, and this is really interesting. In 1919, the cod liver came as a solution to the ricket cure and UV light as a ricket cure. At that time, we had no knowledge about vitamin D3. In 1922, we knew about discovery of vitamin D, and 37, we knew about isolates of vitamin D3, 1937. Again, vitamin D is required for calcium absorption. It was discovered in 1937. And the low calcium diet increasing the calcium absorption was proposed in 1953. 68, we knew about isolates of 25-hydroxy vitamin D. And 69, the VDR was discovered. And 71, the 125-dihydroxy cholecalciferol was discovered. 1971, just around 50 years back, we knew the present molecule, which all of us read in the physiology, 125-dihydroxy cholecalciferol. The skin synthesis of vitamin D, the so-called sun bath, today morning in the walk we were discussing, was known in 1978. Then came lot of work from 71 to 2000, almost 30 years we worked on the transcription, and this 40 years the bone outcome, and this 30 years again associating the vitamin D with different diseases and absorption. And then the genomic era is continuing, what we told, we all are deficient and require vitamin D supplementation. So clinical trials on non-skeletal outcome is on since 2010, and we all are concerned about deficiency of vitamin D3 in our patients. Recent boom in the vitamin D research since 2005. You see, for a long time, almost 60 years, there is no study, no trial, no knowledge. But though we know D3 since long, last 20 years, there is a boom correlating the diseases, and there is a rise in publications and clinical trials. We have injections, we have soft gels, we have syrup, we have tablets, we have granules, we have drops, we have nano formulations, we have mouth dissolving strips. What is the need of so many formulations? It will naturally come to your mind, why so many formulations? We have some medications as tablets, some as injectables, some as liquid. So why it is there? The absorption of vitamin D from the intestine is a big issue. It's a fat-soluble vitamin, and the bioavailability is poor due to its low solubility in aqueous fluids of GI tract. So when we take orally, the bioavailability is a challenge, and it's given in peanut oil was found to range between 55 to 99% in healthy subjects. So the oil-based preparations, they came. So possible factors affecting absorptions were the species, the food matrix, the lipids in the diet, inhibitions of the lipid absorption, the nutritional status of the host, the age, and finally the obesity. You'll be surprised to know in obese people and non-obese people with same amount of deficiency of vitamin D3, the obese has just 50% rise and non-obese has 100% rise. So obesity itself is responsible, and dose has to be doubled. Suppose you are giving 60,000 to non-obese, it has to be 1,20,000 to the obese. It requires double dose because the absorption and the level are less. There are attempts done for improving vitamin D absorption. We see micro and nano capsules, micro and nano spears, the polymet drug conjugate, the micellies, the liposome, and the hydrogel. These are all preparations which come with different promises, and we are all confused regarding what we should go about. And oral vitamin 3, all the preparations that I showed you are easy to take. There is accessibility, there is preference, convenience, and good shelf life. But in any oral formulation, there is issues like non-compliance to the oral vitamin D therapy. You can see here the calcium, vitamin D3, as well as the drugs for osteoporosis are having middle adherence in majority of the groups and low adherence is very high. You can see 80% have forgetfulness and 90% they don't take because of the price, because they don't understand the requirement. Low adherence, 80% was observed in D therapy, 80% and 91% were there in people with low adherence because of the forgetfulness and the price as the reason. So obesity I have already talked. In the obese people, the bioavailability of oral vitamin D is very low, and the decreased bioavailability of vitamin D in the obesity is proved beyond doubt since long. This is a publication of 2000 that I am quoting, which shows the less amount of vitamin D is absorbed in obese. This is what I was telling. 50,000 international unit of oral vitamin D raises 50% less serum vitamin D level in obese people. In non-obese, it raises the normal level. So the obese patient require higher dose of vitamin D is proved in the multiple studies, and that we never follow, that we never differentiate our obese patient from non-obese patients while treating them for vitamin D. So they require at least 2 times higher dose of vitamin D than non-obese. There are publications, and Endocrine Society recommends that higher dose for BMI more than 30 has to be observed, and every patient who has a BMI more than 30 or obese are to be given a higher dose. And the oral therapy is not sufficient because of the compliance issues we saw, cost issues we saw, risk, and considering the long therapy, non-compliance and obesity. We tell weekly for 3 months, then monthly for lifelong. And how many people they take? After a month or 2, they stop the therapy. So chances of reaching to optimal vitamin D level reduces, and maximum benefit in various conditions reduces. So this injection is the game changer for this patient was suggested, and the mega dose ensuring compliance single shot was proposed, and the IM dosing gave a slower than the anticipated rise in the total 25 hydroxy vitamin D levels is shown very well in here. The 1, 2, 3, 4 week shows a gradual increase in vitamin D level. And you can see here a single shot injection or cholecalciferol injection, how slowly it increases the vitamin D3 levels. The limitations of conventional oil-based formulation, which are available by the injection, is the high viscosity, large bore needle is used, hard to push the inject, painful, swelling, and slower absorption rate. So we have oral preparations and we have injectable oil-based preparations which are not very well accepted and increases the problem in rising the vitamin D3 first. The gap in vitamin D3 therapy is various formulation. Oral formulations has non-compliance, cost, absorption, and under-treatment. Injectable therapies are painful, swelling, and the slow response is there. In such situation, need for a formulation which is painless, easily applicable, cost-effective, rapid action, and having sustained response. And there how the aqueous-based preparations were sought for. The first in the world aqueous formulation of cholecalciferol was launched. And you know the oil-based preparations are cholecalciferol and arachis oil, ethylene oilate, and the new formulations are glycopyrrole, surfactant, and other agents along with the cholecalciferol. They are oil and alcohol free and patented by the Government of India for use. And this study shows the PKPD of aqueous cholecalciferol injection, that is around 6 lakh for 2 ml comparing conventional oil-based injection, and these findings will tell you that these are the inclusion and exclusion criteria. This tells you there is no significant difference between the 2 arms, and the PKPD is very impressive. You can see here the blue one is the cholecalciferol aqueous based, and the orange one is the arachidol. So there is rapid dispersion of the cholecalciferol from the injection site within 24 hours, and there is significant higher concentration of cholecalciferol in 1 hour. So there is a first achievement, and within 24 hours the better pharmacokinetics takes it very high. You can see here these 2 labels. This is what the arachidol is, and this is the cholecalciferol is. Just I'll take 1 minute to finish. So the serum hydroxycholecalciferol levels are significantly higher and significantly better pharmacokinetics. And you can see here, by 72 hours, all the patients receiving cholecalciferol has more than 30 nanogram and against non-in-arachital group. So the newer innovation for cholecalciferol enabling physician to overcome the widely prevalent non-compliance, faster correction of vitamin D3, easy application, painless, sustained response, sustainability in obese individual, and ensured achievement of the optimal vitamin D levels for maximal benefit. We have this preparation already launched, the aqueous based preparations. So along with all the oral forms I have shown you, this is a aqueous based preparation and has a faster absorption and earlier achievement of the levels. And by using this, we can compare how fast we can give the benefit to the patient. The decision is yours and time will answer how much we have achieved our expectation. I thank you again for the attention and thank chairpersons, and questions if any we can take up. Thank you all.
We'll take a question.
Thank you, sir. Thank you for your excellent presentation. Sir, as we know, skin color is one of the skin color, black, white, and our Indian skin color are a major factor for the level of vitamin D3 in our blood. Are the vitamin levels of a European and American white person and us Indians and Negro are same? Because the levels of vitamin D3 actually we are seeing in the clinical practice, very few persons are having more than 30. That might be because of our skin color. And Negroes have still less vitamin D3 in their blood. Whether the European standard is applicable to us?
The very right query, Dr. Mishra. Actually, the Indians and the Africans and the black colored people have lesser absorption from the UV light. You know, the UV light factor are less applicable to us. That's why it is accepted unanimously that irrespective of all lifestyle, UV exposure and your own diet pattern, you need vitamin D3 supplementation. Why D3 is becoming important day by day in our country, especially with so many metabolic load. The vitamin D3 supplementation has to be there because the skin absorption part and UV light part is not very effective in intervention, especially in the black colored population. You are very right. Sure.
In our practice, what we see many cases, there is a hypervitaminosis D. It exceeds the normal level. Will there be any side effects, or how to de-escalate it? Or will it, should it maintain it with a overdose of vitamin D3? What is your opinion?
It's very pertinent question, sir. As we know, the less than 20 is too less, and we keep a target of around 50. If for optimal health, we keep a target of around 50. Hypervitaminosis especially is more than 100. Hardly we see hypervitaminosis. Maybe if you are very aggressive in treatment, it is not very common in our practice. But I'll suggest, if you are giving injectable, this aqueous based, a single shot is sufficient. To achieve your target level, single shot is sufficient. And thereafter, taking 60,000 even monthly can maintain the vitamin D3 level very well. So for a long-term maintenance, you can use the oral preparations, and for a first correction, you see, I have seen patients with 2-3 single-digit levels. Even my vitamin 3, in one of the API conference, some of my friends told, let us get a vitamin D checked. Few of the pharmaceutical were doing it free of cost. And I was surprised to see it came 3, when I should have minimum 50 and optimally 80. So I didn't believe. I came back to my place, cross-checked, and confirmed that I am having single-digit vitamin D3, and started taking from that day. It's almost 12 years by now. I am on vitamin D3, maintaining a level of around 60, 70, and it's optimally maintained. So keep a target of maintaining it more than 50 for optimal results. You can give a injection, correct it faster, it's very affordable, and maintain it with a weekly 60,000 capsule for some days if it's not achieved beyond 50, and then you can ask them to take monthly so that it remains in the range, so that the person need not go to the rooftop or the sea beach to get sunlight. Every day we don't have access of this beach like this.
Thank you, Dr. Panda, for your erudite talk. We'll move on to the next session.
Thank you, sir. Thank you, sir. Thank you for your time.
Now, to the next session, the topic is secondary diabetes, endocrinologist perspective. May I call upon Dr. Ankita Tiwari. Introducing her, she is a consultant endocrinologist at Manipal Hospital, Bhubaneswar, publications in international and national journals and books. Received the E.V. Gandhi Award for Excellence in Endocrinology for the best thesis presentation in All India level in March 2019. And she is a member of a Endocrine Society. It's all yours.
Thank you. Good morning, all. So today I'll be talking, at the outset I would like to thank the organizing committee to provide me this opportunity. I'll be talking about secondary diabetes. As my previous speaker, she has wonderfully discussed about the diabetes reversal. So my topic is secondary diabetes, that in certain cases, endocrinopathies can give rise to diabetes, and if we are able to correctly identify, diagnose, and treat them, we might be able to achieve the remission in some cases, or maybe the diabetes will be controlled with minimum drugs or only lifestyle modifications. So these are the few endocrinopathies which can give rise to diabetes. So right from your pituitary gland, certain diseases, thyroid, parathyroid, adrenal, pancreas. So each of these glands, the certain abnormality, excess of certain hormones or deficiency can give rise to diabetes. So the question is, in a busy diabetes OPD, when should we suspect? We cannot screen every patient. When should we suspect? And what are the screening tools which should be used to diagnose these kind of cases? So this we are going to discuss in the subsequent slides. So let's start with the first case. We'll starting from pituitary gland, Cushing's disease. So this 29-year-old female, she is a known case of diabetes. She came to diabetes OPD and she was having very high blood sugars, difficult to control, despite of 3 OHs and insulin. Also, she has mild hypertension. And we can clearly see there is mooning of face, plethora is there, hirsutism is there, and hyperpigmentation on the hands can be clearly seen. So on the high clinical index of suspicion, Cushing's was suspected. The screening test is ODS cortisol, which came to be high, 15.32, and the disease was localized in the pituitary gland. She underwent pituitary surgery, transsphenoidal surgery, and we can see that after the surgery, blood sugar became fairly controlled only on metformin. She was earlier on insulin and 3 drugs, and then after the surgery, after the remission, her blood sugars came to be normal. So first, let's understand the physiology of insulin secretion. We all know that glucose, it enters the beta cell through GLUT2 transporter. This glucose is metabolized, ATPs are produced. This ATP, it stimulates the ATP sensitive sodium potassium ATPase channel, potassium efflux occurs. This causes membrane depolarization, calcium influx occurs, which leads to the insulin secretion. And at the tissue level, this insulin molecule, it combines with insulin receptor, and it starts the signal transduction pathway, which has various effects on glucose metabolism, protein metabolism, and lipid metabolism. So this is how insulin is secreted, and this is how insulin works. So how these hormones causes diabetes, that we are going to see. So in Cushing's disease, we all know there is a cortisol axis, there is a steroid axis. So cortisol inhibit the insulin secretion by causing hypokalemia. It inhibits this ATP sensitive sodium potassium ATPase channel. Additionally, it interferes with the insulin granule secretion, and it causes insulin resistance also at the tissue level. So this is the cause of diabetes in these cases. So for Cushing syndrome and diabetes, a high clinical suspicion is necessary. When we are able to see the clinical features, then only we'll be able to screen it and treat it. And most common cause of Cushing's is exogenous. It should be ruled out in every cases. And the screening test is overnight dexamethasone suppression test, which is a very simple test, easily available. You can easily use it in your patients. The Cushing disease is known to have symptoms which common symptoms which can be seen in obese patients, in alcoholic patients, in pregnancy. So the very specific features of Cushing syndrome which differentiate it from pseudo-Cushing's are features of protein catabolism. So lipid stria, osteoporosis and proximal muscle weakness, these three signs, they clearly differentiates Cushing's from pseudo-Cushing, which we should keep in mind. Coming to the next case. So this 40-year-old gentleman, he is a known case of diabetes. He is following in diabetes OPD since 6 years and nobody suspected. But one resident, he noticed that there is acral enlargement is there and a slight coarsening of features is there. So screening test for acromegaly is IGF-1. So IGF-1 was ordered, it came to be high, 1230. Confirmatory test is post-glucose growth hormone test, which also came to be high. MRI was ordered and which showed a pituitary adenoma. So diagnosis was made and he was also treated with pituitary surgery. After surgery, IGF-1 became normalized and blood sugar also became normal only on metformin. So the pathophysiology, acromegaly is a state of growth hormone excess and it inhibits the insulin action. It causes insulin resistance by activation of SOX gene, that is suppression of cytokine. And it causes lipolysis, increases free fatty acid concentration, which inhibits the insulin secretion. So it interferes both with insulin secretion as well as insulin action. So these are the manifestation of acromegaly, which we all know: acral enlargement, tall stature, coarsening of features, but there is always a spectrum. Not every patient will be having very overt symptoms. So we should always have a clinical index of suspicion. So the symptoms can vary from a very mild phenotype to a very overt phenotype. And the screening test of choice is IGF-1. Next case, prolactin excess. So this 40-year-old male, additional to the diabetes, he was also having impotency, erectile dysfunction, which was not treated with multiple medication he was taking from outside. Testosterone was borderline low. So he was biochemically evaluated and prolactin came out to be very high, 230 nanogram per ml. MRI pituitary showed a large adenoma. So he was started on medical management. The choice of treatment for prolactinoma is always medical management. So he was started on that. Prolactin became normalized and blood sugar levels also came down and he was managed. Additionally, his erectile dysfunction also improved. Fat mass was lost and he became more muscular also. So prolactin also inhibits insulin action through JAK-STAT pathway. It causes activation of JAK2, which inhibit the insulin signaling. Additionally, it causes lipolysis, increases free fatty acid concentration and inhibits the insulin secretion also. So in any case in any patient, diabetes patient presenting with erectile dysfunction, or in female cases amenorrhea, oligomenorrhea or infertility, we should suspect that. Always rule out drug-induced hyperprolactinemia first, that is the most common cause. So just not jump over the MRI pituitary, first rule out the drug-induced hyperprolactinemia, and the screening test of choice is random prolactin levels. Coming to the next organ, thyroid. So this 26-year-old female, she presented with diarrhea, weight loss since 3 years and also amenorrhea was there. So in picture we can see the thyroid swelling, obvious thyroid swelling is seen, and there were signs of thyrotoxicosis also. Thyroid profile was ordered. It was hyperthyroidism, T3, T4 levels were sky high, TSH was not detected. Additionally, she was also having diabetes and premature ovarian failure. So for hyperthyroidism, she was started on neomercazole 30 mg, which was gradually tapered off. And as we can see that as the thyroid levels started coming down to the normal, the blood sugar levels are also being fairly controlled. So thyroxine hormone, we know that it increases the metabolism. So this increases the insulin clearance also, causes relative insulin deficiency, and it causes insulin resistance also by interfering with the insulin signaling pathway. So in hyperthyroidism cases, we should always rule out the other associated endocrinopathy. It can be autoimmune polyendocrinopathy also. And a screening test is a simple thyroid profile. Next, coming to the other next gland, that is adrenal gland pheochromocytoma. So this 51-year-old gentleman, he presented with hypertension and diabetes, incidentally detected to have a left renal mass on ultrasound. In the blood pressure, we can see a significant postural drop. So suspecting pheochromocytoma, the screening test of choice is plasma-free normetanephrines and metanephrine. It was found to be elevated. For the localization, CT abdomen was ordered, and a big left adrenal mass can be seen. And for confirmation, MIBG scan was ordered. So he underwent left adrenalectomy, plasma-free normetanephrine became normalized, and diabetes, which was requiring 2 OHs, it became controlled only on lifestyle modification. So catecholamines, they act through beta-2 receptor and causes insulin resistance by increasing free fatty acid concentration, increasing glycolysis. Additionally, they interfere with the insulin secretion also through alpha-2 receptors. So screening test is plasma-free normetanephrine. It should be suspected in patients with diabetes, hypertension, and paroxysmal symptoms, especially if there is a history of stroke, adrenal mass. And CT scan is the test of choice, but ultrasound adrenal can be carried out simultaneously with renal artery Doppler. In case we are evaluating the patient for hypertension, we do renal artery Doppler, so USG adrenal can be simultaneously carried out. Coming to the next endocrinopathy, Conn syndrome or aldosteronema. So this 55-year-old gentleman, he presented with diabetes and hypertension. He was referred to endocrine clinic for fitness for cataract surgery. There was a very significant history of admission with accelerated hypertension, and it was a resistant hypertension which was not controlled on 2 antihypertensive. His serum potassium was very low. So this is the main investigation which clinched the diagnosis. So suspecting the aldosteronoma, PSC PRA test, plasma aldosterone concentration, plasma renin activity was ordered. This is the screening test of choice, PAC by PRA ratio. If ratio is more than 20, then it clinches the diagnosis, and that ratio was 749 in this case. So a diagnosis of Conn syndrome was made and patient was surgically operated. So this aldosterone, it causes insulin resistance by causing hypokalemia. If the potassium level are low, it will interfere with the functioning of this sodium potassium ATPase. So the insulin secretion will be hampered, and also it will causes insulin resistant at the tissue level. So aldosteronism should be suspected in patient with diabetes and resistant hypertension, hypokalemia, and the screening test is PAC by PRA ratio. So coming to the next gland, pancreas, various neuroendocrine tumors can give rise to diabetes, but they are very rare. Most common of them is glucagonoma, which presents with diabetes, weight loss, and a very characteristic skin rash, necrolytic erythema migricans. So maximum incidence of diabetes is in this condition. Other neuroendocrine tumors which can give rise to diabetes are somatostatinomas, gastrinomas, very rarely insulinoma. Insulinoma usually presented with hypoglycemia, but in post-surgical case it can present with diabetes as well. So we come back to the previous slide, that when should we suspect the secondary endocrinopathy? If the patient is presenting with other comorbidity or with certain clinical features like stria, acral enlargement, coarsening, some features like erectile dysfunction, infertility, something other than the usual diabetes, we should suspect. The screening tools, now we know all the screening tools for various endocrinopathy, and of course, the high index of clinical suspicion is required, and the disease presentation is always a spectrum. Every patient will not present in a very overt form. Sometimes it could be a very mild variant also. There is always a spectrum. Screening tools, we know. So let's summarize what we have been discussing over the last 15 minutes. So in pituitary Cushing syndrome, it will present with catabolic features, screening test, overnight dexamethasone suppression test. Then acromegaly present with acral enlargement, IGF-1 is the screening test. Prolactinoma will present in males with infertility, erectile dysfunction, in females with oligoamenorrhea. Serum prolactin is the screening test. Hyperthyroidism will present with thyrotoxicosis symptom. Thyroid profile is the screening test. Hyperparathyroidism also can present with diabetes, and it can be diagnosed with serum high calcium, low phosphorus, and high PTH levels. Adrenal gland pheochromocytoma will present with classical symptom of paroxysm. Sometimes paroxysm may be absent, but the screening features, the screening test would be plasma-free normetanephrines. Aldosteronoma will classically present with resistant hypertension, hypokalemia. The screening test, PAC by PRA ratio. Pancreas tumors are rare. And I'll end my presentation with this wonderful quote. Thank you. Thank you for the patient hearing.
We'll take up some questions.
Yes. Yes. Yes, sir.
Excellent presentation. But what is the type of diabetes, characteristic of diabetes, when you suspect some endocrine cause may be there?
Yes, as I have already discussed, if there are certain clinical features which is not fitting into the diagnosis, young patient, very high diabetes, additionally some features like menstrual irregularity or maybe stria, hyperpigmentation, hirsutism, then only we'll screen. We cannot screen in every patient, it's not possible.
Correct. And I think another important cause is if you are treating diabetes, very high blood sugars and requiring very high dose of insulin. And as you mentioned in your acromegaly patient, signs may be very subtle signs
Very
of
mild.
acral enlargement. People may not be looking those things and giving lots of insulin, still sugars are uncontrolled. So this one, like in Cushing's also, subtle signs of Cushing's and sugars are very uncontrolled. Then you suspect some endocrine causes may be there.
Yes.
Thank you.
I'm not able to hear.
Secondary diabetes due to pancreatic calcification.
Yes.
Yeah.
But that is a separate entity. Pancreatic diabetes is a separate entity in the classification of diabetes. I was just focusing on the secondary causes of
Only
diabetes.
endocrinopathy.
Endocrinopathies,
Okay.
yes. Thank you.
Okay, thank you, Dr. Ankita.
We'll move on to the next session, and I thank the chairpersons and the speakers for the nice session. We have for the next session Dr. Shantanu Kumar Jena, member of organizing committee from Puri, and Dr. Aditya Mishra from Cuttack, and Dr. Amitabh Mohanty from Bhubaneswar to chair. I request the chair to come on the stage. Yeah. Yeah, I think Jenna not here. You can start. I request M.K. Chotra sir to please help us in chairing this session so that we can take it further. We have speakers, Dr. Kalpana Das, Dr. Harivallabh Mahapatra and Dr. J.B. Kanwar. Over to chairperson.
Good morning. I think all of you had your cup of coffee. Let's go to the next session. I would invite Dr. Kalpana Das, madam. 1 year senior to me at undergraduate days. I still remember her, an academic achiever, Chief of Diabetes and Endocrinology, Apollo Sugar Clinic, Raipur and Bilaspur. Narayan Hudale Raipur Honorary Faculty, American Takshila University. She has been a professor of endocrinology, Apollo Hospitals Education and Research Foundation, AHERF, Honorary Faculty at Public Health Foundation of India, Board Member of Ayush Medical University, Chhattisgarh, and Editorial Board Member of Apollo Medical Journal in New Delhi. Her topic is metabolic associated fatty liver disease and the role of dual PPAR saroglitazar. So let's hear an interesting topic, quite prevalent in society. It's over to you, madam.
Just a housekeeping announcement. The PG quiz is in the Hall B starting. So any postgraduate here are requested to join there. Our free paper session is over. And ma'am is one of the best endocrine faculty in the country, and she is the daughter of the soil, I'll tell. Over to you, Kalpana ma'am.
Thank you, Chair, and thank you, Jayant, for inviting me. So good morning, everyone. So I'll be talking on MSLD and the role of dual PPAR saroglitazar. So I'll take you through from MFLD to dual PPAR saroglitazar. Minute. Okay. So current scenario in our country is we have a silent disease apart from diabetes, hypertension and many non-communicable disease, that is the fatty liver disease. This is growing exponentially in India, is the most common cause for CLD and many metabolic diseases. And you will be surprised to know that India is the first country globally recognized and globally integrated NFLD into the non-communicable disease activity, that is 2021. So continuum of prevention and care needed to address this spectrum of disease, that is NFLD, because that leads to many metabolic syndromes. And it has emerged as the main cause of cirrhosis, hepatocellular carcinoma, as well as liver transplantation. You can see the spectrum of the disease, that is NFLD. It starts with fatty liver, goes through NASH, and finally ends in cirrhosis, and some cases they can be converted into hepatocellular carcinoma. So recently this NFLD has been revised as a name as MSLD, that is metabolic dysfunction associated steatotic liver disease. Steatotic liver disease, if you want to define this, that means fat deposition in more than 5% of hepatocytes in liver, plus one of the few metabolic risk factors in the form of elevated TG or low HDL, type 2 diabetes mellitus, the presence of pre-diabetes, obesity, and also hypertension. So that means steatosis has to be there, plus one of the other risk factors that has to be there. So that is how we define MSLD. A renaming of MSLD as a nomenclature has been released in June 2023, has been accepted by many organizations. So why do we need to know about MSLD? As you know, this is a multisystemic disorder and an independent risk factor for the overall mortality. The root cause for this disease is the insulin resistance, and this leads to fatty liver development. And in this disease, liver is the victim. And when fatty liver occurs, that leads to the many outcomes of the fatty liver in the form of cardiovascular disease, cirrhosis, hepatocellular carcinoma, and as well as increase in the motility. MSLD has many extrahepatic complications, as I said, like increase in the death because of CVD. But the death in NFLD is not because of the fatty liver or liver-related disease or malignancy. Rather, the death is because of the CVD. That is because they have many shared risk factors in the form of presence of metabolic syndrome, hyperlipidemia, obesity, as well as diabetes. So this is the reason why most of the patient, about 42% of the patient, they die of CVD. Next, let us have a look at the magnitude of the problem, the global and the Indian scenario. So we have about 25% of the population affected by NFLD, and has been suggested that probably that will rise to 50% by 2040. And 38% of our population are suffering from NFLD, 58% in patients with metabolic disorders, and pediatric group also, they have been affected by about 35%. So this prevalence is higher with diabetes, so we have to be very careful, even in pre-diabetes, obesity, even PCOS, we are not taking care of the NFLD, or we are not screening the NFLD in PCOS patient. Even hypothyroid, they have a higher incidence of NFLD, and menopause also. So menopausal, post-menopausal women also, they need to take care of this entity, and metabolic syndrome, this is already there. So how insulin resistance causes this disease? Insulin resistance, as I said, is the root cause for the development of atherosclerotic diabetic dyslipidemia with MSLD. They cause adipocyte dysfunction, causing decrease in the adiponectin, increase in the free fatty acid, and increase in the triglyceridemia, and that causes hyperinsulinemia as well as hyperglycemia. Apart from that, there are many environmental factors like diet irregularity, dietary factors, sedentary lifestyle, and also genetic polymorphism in the form of genetic polymorphism of the PNPLA genes. So all these things lead to fatty liver, then lead to NASH, causing lipotoxicity, inflammation, apoptosis, and the oxidative stress. Finally, they end up in end-stage liver disease as well as diabetes and metabolic syndrome. There is an interplay between the insulin and metabolic complications like higher triglyceride level, diabetes mellitus, and MSLD. There are two theories for the pathogenesis. One is two-hit hypothesis, second is multiple hits hypothesis. In the two-hit hypothesis, steatosis and free radicals, they are released. And in the multiple hit hypothesis, like in diabetes, there is increase in the oxidative stress, lipid metabolism dysregulation, immune system modulation, mitochondrial dysfunction, epigenetic and genetic factor, along with the dietary and lifestyle factors that lead to NFLD, NASH, and finally landing in liver cirrhosis and hepatocellular carcinoma. And these two conditions like NFLD and the metabolic condition, they go hand in hand, because you can see here there is high association of metabolic conditions with NFLD. Like 90% of the obese patient, they have NFLD, 70% diabetic patient, 68% hypertension patient, 83% of high TG levels, 71% of metabolic syndrome, they are all having NFLD respectively. So there is an association of NFLD and diabetes mellitus. As you can see here in this slide, NFLD develops before the development of type 2 diabetes mellitus. This has been documented by a meta-analysis of 33 studies, about 5 lakh individuals. They had 30% of their patients having NFLD and about 27,000 cases of incident diabetes over a median period of 5 years. So the conclusion from this study is that NFLD is associated with about 2.2-fold increase in the risk of incident diabetes, which is directly proportional to the severity of the NFLD. And here is the relationship between the NFLD and the type 2 diabetes mellitus, which is very dynamic and also reversible. NFLD certainly leads to a new incident of type 2 diabetes mellitus. In this study, they had categorized into 7-8 groups. Those who had no NFLD, having persistent NFLD, having NFLD developed at midpoint of the follow-up, NFLD resolved at midpoint of follow-up, and so many. So amongst them, it is very interesting that those patients who had persistent NFLD, they had a higher risk of developing type 2 diabetes mellitus, that is incidental diabetes mellitus. And NFLD is also more useful in predicting incidence of diabetes mellitus and onset than the BMI, even when considering changes over the period of time. So here the scenario of NFLD in diabetes in India. There is higher prevalence of grade-wise steatosis and fibrosis. If you look at the steatosis, about 75% had steatosis and 29% liver fibrosis. So that is the reason why we need urgent attention in the diagnosis, because we are taking care of diabetes, hypertension, but at the moment what I can see in our OPD, we are not taking and looking at screening proposals in our OPD for NFLD. So this slide shows about the type 2 diabetes associated with higher clinically significant liver fibrosis in India. So this is on the basis of the higher BMI, AST, ALT values as well as lower platelet counts which were associated with clinically significant liver fibrosis. See, this basically highlighted the importance of screening programs in our setup. And rate of progression, when the patient is having type 2 diabetes mellitus, that leads to progression of fibrosis at a higher rate in MSLT patients. You can see here about 448 patients. So progression over a period of 12 years was about 73%. And this progression and mortality also, this is different in non-diabetic and as well as diabetic patients. So those patients who had no diabetes, their progression was less as compared to the type 2 diabetes mellitus. In type 2 diabetes mellitus, the conversion from NFLD to NASH, cirrhosis, hepatocellular carcinoma and liver transplant was about double and triple as compared to those without diabetes mellitus. So we have to be very careful while handling all type 2 diabetes mellitus. At least we should have a screening program so that you can pick up the NFLD cases so that we can prevent the consequences that is related to NFLD. So this is also related to duration of the diabetes. The longer is the duration of the diabetes, so it was seen that the liver-related events in case of type 2 in a case of NFLD was much higher. That is, the events due to liver events and the all-cause mortality were also higher. So duration also has to be taken care. And MSLD is also associated with more CV events compared to NFLD. You can see here risk of CV events, fatal CV events, cumulative all-cause mortalities, they were much, much higher in case of NFLD as far as the CVD is concerned. And here is a very interesting finding that we can see here in our day-to-day practice. If you don't find to do the fibroscan or FIB4 analysis, all those things, so we can just go ahead with just a simple ratio, that is TG to SDL ratio, which can be a surrogate marker for NFLD. So what has been seen in this study, the TG and SDLC, which is independently associated with NFLD, in apparently healthy individuals and may be used as a surrogate marker for NFLD, and further we can go ahead with other testing that we can have. Here is the importance of prompt screening, diagnosis, treatment, when, how and why. So that for that matter, we need to have CAP, that is knowledge, attitude and practice. As you know, this has been associated with many long-term complications, extrahepatic complications, and this is the most, CVD is the most common cause of death. So initial investigation that you can go for is fasting blood glucose, postprandial blood glucose, A1C, lipids, EGFR, thyroid function test, and after the diagnosis, lifestyle modification is the important treatment modality. So this is for the screening. So you can screen these following cases like obesity, type 2 diabetes, pre-diabetes with elevated liver enzymes, hypertriglyceridemia, lowers HDL and hypertension. So you can go ahead with screening for this patient at least. So what are the screening tests? We can go for non-invasive tests like NIT, scores in the diagnosis of NFLD, FIB4 index that should taken into account with the platelet, AST, ALT. So it's, if when it is less than 1.3, it is normal. More than 1.3 should be considered for further diagnosis. And APRI test, NFS, FAST test, VCT, and MRE, and liver biopsy. Amongst them, for screening, FIB4 is very important, and also triglyceride SDL is that ratio is very important. But you want to confirm the diagnosis, you can go ahead with the MR elastography test, but the gold standard of the diagnosis is liver biopsy. And apart from that, obviously, you should also go for AST, ALT, abdominal sonography, CBC, PT, and GGT. Other different methods for diagnosis of fatty liver. Simple method is palpation. We can palpate a liver if it is enlarged fatty liver, but it may be a basic test, but it is insensitive. Liver biopsy is the gold standard, but cost is very high. It is high risk also. High sampling error is also there. High intra-observer vibration variation is there. It is painful and not suited for the follow-up. However, if you have a FibroScan facility, this is definitely very good. Very easy and fast method, non-invasive. Large sample size also can be done in 1 hour, 2 hours. No ultrasonic training is required. Immediate result is there, and it is also reproducible. So this is the flow chart for diagnosis of MSLD. So you can have an incidental finding of raised liver function, liver enzymes. Also you can see those patients having obesity, diabetes, and you can go for a screening with ultrasonograph. And incidental finding in the ultrasonograph while in evaluating other diseases. So all these cases should undergo the non-invasive testing like FIB4 NFS. If they are low risk, you can repeat this after 2 to 3 years. Intermediate risk, you can go for PCT, that is elastography. High risk also, you can go ahead with that. If there is no risk, then you can repeat it after 2 years. And if there is finding, then you can refer the patient to gastroenterologist. This is the FIB4 test that can exclude the presence of advanced fibrosis. This is very easy and cost effective. 4 parameters are required: age, AST, ALT, platelet count, and can rule out the presence of fibrosis. And this is very easy, reproducible, and very sensitive and specific test also. So the parameters that we use in BCT, they are basically the LSM and the CAP system. The LSM is that is a non-invasive quantification of the liver fibrosis, and the CAP is the non-invasive quantification of the liver steatosis. This is how you interpret. The LSM is there stage like F0 to F4. If it is less than 7%, there is absence of fibrosis. It is more than 16%, there is definitely cirrhosis. And CAP score, so that is also depends on that is actually the fat deposition. So S0 to S3, the less is less than 237, and if it is more than 293, so that should be taken care. So this is the management protocol. So obviously you have to follow the lifestyle modification. The first is you have to lose weight as much as possible, so that is the best treatment available without any drug, addition of the drug. Then you have to manage the associated comorbid conditions like obesity, diabetes. Pharmacotherapy and bariatric surgery also has a role. So as far as the weight loss is concerned, that plays a major role. But as you lose weight, there is definitely sustained improvement in the outcome in the sense like steatotic improvement, ballooning improvement, resolution in the NASH, and the regression of the fibrosis. But however, the sustaining the weight loss is a challenge for all of us. So that is the reason why we should actually counsel the patient, so that sustaining the weight loss is very important. So treatment with saroglitazar is very important, and that is the only drug available in our country for treating this, and other drugs are there. So that has been recommended by the NCE and in India, and that is recommended to treat the NFLD as well as atherosclerotic diabetes dyslipidemia. Mechanism, it is just works on like PPR agonist, alpha and gamma, and that lowers the lipid profile and also lowers the blood glucose, and also takes care of insulin resistance, dyslipidemia, NASH and NFLD. Hypertriglyceridemia also is taken care by this drug. This improves the glucose metabolism, insulin sensitivity index as well, and also efficacy wise, this is a very efficacious drug and very effective in biopsy proven NASH also. You can use this drug in biopsy proven NASH also. And all the organization, that is INSL, they recommend saroglitazar in NFLD treatment for minimum 12 months. So treatment has to be continued at least for 12 months. And other treatment modalities like metformin, off-level, vitamin E, PPR, gamma agonist, it has been discussed in the morning, UDCA, obetiolic acid, and role of GLP receptor analog and SGLT2, basically they reduce the NFLD just by reducing the weight, by enhancing the weight loss. So this is how they reduce the NFLD. This is the paper that I had seen comparison of lifestyle modification and the bariatric surgery. Lifestyle intervention in NFLD was assessed at baseline after 6 months. It improved the fibrosis, but there is no resolution of the fibrosis. Whereas when bariatric surgery was done in certain cases, the resolution was fibrosis was by 40%. So improvement and resolution both are different terms. So definitely bariatric surgery is one of the best treatment available these days. Apart from that, medical treatment should be done through the saroglitazole, maybe GLP-1 receptor analog, and to some extent as anti-diabetic drug we are using GLP-1 receptor analog and the other drugs. So summarizing, MSLD is a metabolic dysfunction which is associated with steatotic liver disease, which is redefined from NFLD. Association of at least one cardiometabolic risk factor like obesity, type 2 diabetes, hypertension, hypertriglyceridemia, low SDL with SLD is considered as MSLD. Screening with USG, FIB4, VCT, they are very strongly recommended in our scenario. Lifestyle modification and weight reduction is the mainstay of therapy apart from the medical therapy and bariatric surgery. Drugs like saroglitazole is the only approved medication in our country, that is NFLD with metabolic disorders, which can reduce the liver enzyme, liver fat and fibrosis score as well. Thank you very much for your kind attention.
Thank you, madam. Floor is open to questions.
Thank you, madam. I'm here, Dr. S.K. Mahapatra. Very often you are getting cases of fatty liver in our ultrasound. Now today these investigations available doing at a fibroscan and this CAP score and you said FIV4 and all that. Now all these scores, all these modalities for confirming muscle is higher. Now you have started saroglitazole. At what time you will expect that the fibrosis will reverse or it will come to normal? Suppose it doesn't happen, what is the next step?
See, there are so many modalities. It's not only the saroglitazole which is going to work. Suppose I have fibrosis or NFLD. So obviously I will start with saroglitazole. If I am obese, I will also add metformin. I will also add GLP-1 receptor analog. If I am severe diabetic, maybe I will add on SGLT2 inhibitor. Otherwise, if it is not responding, then I don't know, maybe in next 5 years something else will come.
No, despite that, we will correct everything. No doubt, we will ask him go for this walking, exercise, correct your glycemic level, all those things that will be corrected. In addition that, we will be giving also, in trial also we are giving other modalities. But we will wait for say 6 months, 1 year, but there is no improvement. We are suspecting, yes, here is a very close patient relation is leading towards a cirrhosis liver. Can we prevent at that stage, preventing going to cirrhosis, or let us wait and think for further drugs to come?
It's just checking obesity, that's it.
Yes.
So we need just baseline counseling and reducing the weight. It's all lifestyle modification, so we have to modify everything maybe at the baseline.
Just would like to give a comment, sir,
Madam,
to your question. Dr.
yeah.
Cecil Mahapatra, sir, question. How often physicians are advising for liver scan? I just want to know.
Fibroscan.
Yeah, the fibroscan. How often you are advising? After checking the ultrasound, yes, I'm seeing few hands raised. So that is the point. The message to the audience is, once you see the USG, and it suggests a fatty liver disease of 2 or beyond, ask for a liver scan. And it is being done in the city, in Bhubaneswar. So what is important is, by doing that liver scan, you can know at what level the liver has gone through the changes. So if it is like above 10 or above 13, then probably you are dealing with a very severe case where it is going on to cirrhosis. So that is important. You have to ask for the test. And secondly, the most important thing is the counseling. How often, every time, in addition to adding GLP-1, in addition to adding SGLT2 inhibitors, how often you are advising the patient, giving 2 minutes for losing weight? You know about the INDIAB study. They have spoken so much about the truncal obesity, about the generalized obesity. So obesity is the #1 disease in the world now. And that is the root cause of all diseases. So I think we need to focus on reducing BMI.
Obesity only.
But sir, the lean Indian hypothesis, we are seeing so many lean and young people with altered LFT and not even diabetic. I mean, how do we go about just advising another drug or even advising fibroscan? They seem quite, I mean, I hope it is not, we are not being guided by the pharma and the investigative.
Actually, there are many works to be done. 4 days ago, I saw a type 1 diabetes patient, 6-year-old, uncontrolled diabetes mellitus. And she had fatty liver grade 3. Can you imagine? Very thin built, poorly uncontrolled. 6 years, what will you do? It's a question.
In such cases, there is no doubt at least. But
Yes.
in young and lean individuals with only altered LFT and some higher echogenicity in the ultrasound, it feels very, I mean, we are at a loss whether to really advise them to go for fibroscan. If there are no sufficient risk factors, even then people are having these altered LFT.
Now, what is important is you need to sensitize them. The point is, we are going through a phase of evolution where we are seeing the final picture maybe 5 to 10 years down the line. But you need to sensitize this population who come for counseling or for consultation, that you have to look at that and try to reverse it. That's all.
But young
needs
people
lots
in
of awareness,
25,
actually.
30 years, they have just started earning and you start telling them don't eat.
No, it
Very
needs lots
difficult.
of awareness.
Yeah,
Lots
it needs
of
a lot of
awareness.
awareness and counseling.
Counseling.
Yes, I think Colonel Datta wants to say.
Ma'am, now in our hospital we have an in-house fibroscan which is older. So we used to do medium stiffness index, MSI used to do. Now some of the companies, they are approaching us,
They are
they have
doing.
CAP and MSI both. But problem is our hospital will not again invest in another this thing. So whether this median stiffness index is good enough or actually CAP is...
At least you can pick up some. What I do in my OPD, I do it every monthly. I ask the pharma people, they do it. We give appointment to the patient, especially the diabetic obese patient. We pick them up and at least counsel them for weight loss programs.
Which is more sensitive, means this, this MSI stiffness index or CAP, which is better? If it is
think
MSI,
that
I can...
LSM is more sensitive. LSM. That is more. That is fibrosis index. That is more important. Huh. That's why I cancelled actually. I cut them down because it was all covered. He described so well. I just focused on saroglitazar.
Thank you, madam. I think
Thank you.
it has been quite interesting and quite enlightening. Thank you.
Thank you all.
Next, I invite Dr. Hariballa Mahapatra. He is a consultant in Sebayan Diabetic Center, Puri. He has got master's degree in health science and diabetology from Annamalai University, Tamil Nadu. And he has special education and training in diabetes and endocrinology. Besides that, he's son of my classmate. Okay. Dr. Mahapatra, please start.
Thank you, respected chairpersons and distinguished delegates who are attending the session. And I'm very grateful to the organizing committee for giving me this platform to present this topic. And yesterday, Dr. Utkal has a very similar session on one of these molecules, that is NSMRA, and that has made my job quite easy. And with this, I'll be talking about the burden of the disease. At the same time, we'll also discuss about the mechanism of action and how to prescribe this molecule and the evidence behind the prescription. So we all know that diabetes is increasingly, we find most of the patients with diabetes in India, and surprisingly, the number of patients with diabetic kidney disease has also gone high. And that is disproportionately rise in the diabetic patient, diabetic nephropathy patients has been also seen. And if you see the number of patients contributing to the CKD, more than 50% of the patients who are having CKD, they belong to either hypertension or diabetes. And in the Indian subcontinent, studies have shown that the incidence or prevalence of CKD is almost 17%, and side by side, patients who are diabetic, they are more prone to get these CKD complications in comparison to rest of the other people. And there are studies which show that almost 35 to 40% of the Indian patients with diabetes are having CKD. And if you see the continuum of this complication of cardiovascular, kidney and metabolic conditions, there is a very, they're very interlinked. They share a common pathophysiologic mechanism. And we know that diabetes is the major reason behind end-stage kidney disease and the patients requiring renal replacement therapy. It may be dialysis or transplantation. At the same time, it has also been seen that in the foreign countries like US, it contributes to almost three-fourths of the patients with CKD. They belong to this diabetes or hypertension category. And at the same time, we know that patients with diabetes are more prone to get these complications. Particularly, the cause of death in patients with diabetes is because of cardiovascular complications. And the presence of CKD that predisposes the patient to further increased risk of developing vascular mortality. And cardiovascular mortality, it accounts for almost 50% of death in patients with advanced CKD or end-stage kidney disease. And this particular slide shows the link between the risk of cardiovascular death and CKD in patients with diabetes. As you see, there is an increase in the risk of death in patients who are having diabetes as such. That has been already proven. At the same time, if the patient is having CKD, that further increases the risk of death. And if the patient is having both, like diabetes and CKD, the death because of cardiovascular diseases rises almost 6-fold. So it is quite big number, and we need to address this concept and these conditions. And at the same time, the albuminuria status and the estimated GFR, these are the two different independent conditions that predispose the patient to further into the cardiovascular mortality. And it has been seen that as the albuminuria increases from maybe 30 to 300 or beyond 300, the risk increases many folds. At the same time, as the GFR declines, the risk also further increases. And when there is a combination of low GFR and with high urinary albumin creatinine ratio, the mortality is further increased, and that is multifold. Coming to the driving forces, which conditions that drive the CKD progression in patients with diabetes, we know about the hemodynamic conditions, because hypertension, as I told, that is one of the major risk factors. At the same time, it's the metabolic conditions that play a significant role in driving the CKD progression. And if you see the other concept, that is one of the maybe not exactly newest concept, but one concept is there, that is inflammation fibrosis. That is also one of the vital concepts, and currently we don't have any particular medication to address this concept. And all these risk factors, they predispose the individual to several types of changes, both anatomical and physiological changes in the nephrons, leading to CKD progression. And if you see the hemodynamic conditions, there are molecules like AC inhibitor, ARBs, TZDs, and SGLT2 inhibitors, which can address the hemodynamic conditions. At the same time, SGLT2 inhibitors are also capable of controlling the metabolic state of the individual, GLP-1RA, metformin. These are quite understandable entities which delay the progression by controlling the metabolic and hemodynamic properties. But as such, there is no molecule which can address the inflammation and fibrosis till couple of years back. And I should say that despite having all these molecules, the mortality rate is quite high, and the patients, they do land up in complications like end-stage kidney disease or renal replacement therapy. Despite we are having so many molecules, but despite that, the conditions are also on the rise. So we are missing something in between. So maybe this inflammation and fibrosis, if we can address this concept and condition, we can reduce the risk of complications in patients with diabetes. And here comes the molecule that we'll be discussing now. So it's the mineralocorticoid receptor overactivation that plays significant role in the pathogenesis of diabetic kidney disease, or maybe in chronic kidney disease as a whole. So there is overactivation of this mineralocorticoid receptor pathway, and this MR pathway that is vital in controlling the gene expression for various types of mechanisms like pro-inflammatory cytokinins, reactive oxygen species, and pro-fibrotic factors. So this leads to a case of inflammation and fibrosis, which gradually gets translated into the clinical side by damage to the kidneys and heart. At the same time, it has got impact on the vasculature as well. So all the things that gets affected by this MR overactivation. So here comes the golden molecule that we'll be talking about, that is phenyrenone. It's a potent mineralocorticoid receptor antagonist, and that inhibits the inflammation and fibrosis in the kidneys. That has also been documented in several studies. You can see the various types of cytokinins like PAI and MMP. These are decreased by this molecule, and that is quite effective in preventing the complications, renal complications in diabetes as a whole, but even that is effective in patients who are non-diabetic as well. That has also been studied extensively. And if you see the effect on the blood pressure, it has got very negligible impact on the blood pressure, and there is a comparison between epredolol, that is another MRA, and in comparison to epredolol, the reduction in the blood pressure is not much with phenyrenone. So it is quite effective molecule in terms of reducing the risk of vascular complications, particularly reducing the fibrosis and inflammation in patients with diabetic kidney disease. And that if you see the impact on the heart fibrosis, that is also quite effective, and this has been found in the mouse model, and they are quite effective in reducing these complications, particularly pertaining to the heart. Now, if you compare between the other available molecules like the other aldosterone antagonist, that is steroidal aldosterone antagonist, and compare that with phenyrenone. Phenyrenone is a relatively bulky molecule, and that is the reason it cannot pass the blood-brain barrier, and it has got several other advantages over the other conventional aldosterone antagonists like spironolactone or epredolol. And if you see the potency against the receptors, it is quite effective, and you can see the effect is quite almost same as that of here you can see the selectivity for MRA. It is quite effective as that of at least epredolol, but it is more effective than that. And because of this selectivity nature, we see very less risk of erectile dysfunction or sexual dysfunction that is seen with the other two MRAs, that is the steroidal MRAs. And sexual side effects are very less. It doesn't cause blood-brain barrier. At the same time, if you see the half-life, it is quite less in comparison to the other MRAs. And because of this short half-life, it has got also other advantages, and it is possible to reduce the risk of hyperkalemia, which is conventionally seen in the other MRAs. That is not there with phenyrenone. And if you see the effect on this molecule on the systolic blood pressure, it has got very minimal impact on the systolic blood pressure, and hardly there is any change in the blood pressure in comparison to placebo. So close to 2.5, 2.7 millimeter blood pressure reduction, that is very negligible. And because we are talking about a molecule in the diabetes forum, then what is the impact of this molecule on the HbA1c? Honestly saying, there is hardly any difference, 0.03. So it doesn't make any sense here. And this molecule we can prescribe to patients even with a higher degree of glycemic derangement also we can prescribe. And as I told, hyperkalemia is not there because of the short T-half. Coming to the evidence, why this molecule has been discussed in this particular forum. So Fidelio-DKD, that is the phenyrenone in reducing kidney failure and disease progression in diabetic kidney disease. And this is the study which focuses the impact of phenyrenone in patients with kidney failure and diabetes. And there is another study very similar to this particular study, which where we are focusing on the vascular component, particularly the cardiovascular component. Here we are discussing about the renal component of phenyrenone. And a good number of patients were recruited. 5,700 patients were recruited for this study, and they are given either 10 milligram of the phenyrenone or 20 milligram phenyrenone, depending on their EGFR. And this was a phase 3 randomized double-blind placebo-controlled trial, and the objective was to see the impact of this molecule on the renal parameters, particularly the patients with how they are progressing to the end-stage kidney disease, or how their urinary albumin creatinine ratio is improving. So all the patients at the baseline had a higher urinary albumin creatinine ratio, and this particular slide shows the impact of phenylenone on the various renal components like kidney failure, renal death, or sustained more than 40% decline in the eGFR, and it was found to be very much effective. You can see the hazard ratio, that is almost 18% decrease in the risk from the renal point of view. So it is quite effective molecule, and if you say the impact on the urinary albumin creatinine ratio, there is also a substantial decrease in the urinary albumin excretion rate over the period of study, and it is visible from the very beginning. That is, from the 4 month onwards, you can see the reduction in the urinary albumin creatinine ratio, and sustained GFR. That is also very much sustained decrease in GFR. That is also very much improved with this molecule. Now coming to the cardiovascular outcome trial of phenylenone. Again, the name of the study is FIGARO-DKD. The previous one is Fidelio-DKD, but here it is FIGARO-DKD, and it has close to 7,500 patients enrolled in this particular study, and the individuals are given 10 or 20 milligram of phenylenone depending again on their GFR, and at baseline the patients had CKD with diabetes, and either they could have a GFR below 90 ml, or maybe depending on the conditions, even they had some retinopathy with high urinary albumin creatinine ratio. And what the study showed, it showed that the primary composite was the improvement or the cardiovascular death or non-fatal or fatal myocardial infarction, or even fatal stroke was also looked into, and hospitalization for heart failure. You can see all the improvements have been documented with this molecule in the phenylenone group, and there was a significant decline in the incidences of cardiovascular endpoints in this particular study, and there is a 13% risk reduction has been documented in the primary composite outcome. Now they combined together both the studies, that is Fidelio-DKD and FIGARO-DKD, and the name of the study they did is it was a fidelity study, which analyzed the pooled data from both the studies, and they found out that this molecule was quite effective, and both the studies combined together showed a 14% decrease in the cardiovascular endpoint, and again a 23% risk reduction in the renal point of view. So it was quite effective, and because of this their effectiveness, till now we are discussing about the glycemic management. It should be individualized as we always talk, and glycemic goal should be the priority. At the same time, we should not focus the control of blood pressure, lipid parameters, and agents which can prevent the vascular complications and renal complications. So now we have got MRAs available with us, and these are molecules that should be given with the highest possible DAS blockade, and additionally we can give SGLT2 inhibitors and NSMRA. So these three molecules, they are primarily meant for preventing the cardiovascular and renal complications in patients with diabetes, and it has been approved in the USA and in India also with the same indications, that is patients with diabetes and CKD, to reduce the risk of sustained eGFR decline, end-stage kidney disease, cardiovascular death, non-fatal myocardial infarction, and heart failure hospitalization. So this is the indication for this molecule. Now how to prescribe this molecule? It should be prescribed only when the patient's GFR is adequate, and it should not be initiated in patients with low GFR. That is, if the GFR is below 25, we should not start the patient on phenylenone, and it should be discontinued in patients with a GFR below 15 ml per minute, and it should not be prescribed to patients with hepatic impairment, Addison's disease, and those patients who are on clarithromycin and ketoconazole. This group of molecules, it should not be prescribed. And as with any of the MRA, the major concern is about the rise in the serum potassium level. but we need to check the potassium level. But anyway, I should say that this is a relatively safe molecule in terms of the potassium, and we can start the molecule when the serum potassium is less than 5 ml per milligram per deciliter, and gradually we need to check the potassium level at regular intervals, maybe at the end of first month, 4 month, and every 4 month following that. And depending on the potassium level, we should try to uptitrate the dose of the molecule, and we should try to make the molecule 20 milligram once daily. And even if we are starting with 10 milligram, gradually we should uptitrate the dose, and we should go for 20 milligram. So based on these evidences, several international guidelines, they have promoted the molecule, and even the ADA, EASD, and KDIGO guideline, they all promote this molecule on top of the standard therapy, that is SGLT2 inhibitor and highest tolerated dose of AC inhibitor or ARB. So coming to the final slide, CKD is in patients with diabetes, it is linked to high risk of cardiovascular disease and end-stage kidney disease. SGLT2 inhibitor is recommended as the first line therapy, followed by NSMRA, that is phenomenon for persistent albuminuria. And MR antagonists have got anti-inflammatory and anti-fibrotic components beyond blood glucose and blood pressure control. And phenomenon effectively slows kidney disease progression and reduces the cardiovascular events compared to placebo. Hyperkalemia is a potential complication, but it's manageable, and we need to check the serum potassium level of the individuals on a regular basis. Thank you.
Thank you, Dr. Mahapatra, for enlightening us with a new molecule. Though diabetes and CKD are common, and there are very few drugs available now, Peninon is a new addition, but our experience in this drug is very limited. We have seen once you start with 20 milligram, the incidence of hyperkalemia is more. What is your reaction to it?
Sir, in that case, we need to check the serum potassium level at a regular interval. Whenever
what is the regular interval?
Sir, suppose we are uptitrating the dose, or we are initiating the dose. After 1 month, you need to check the serum potassium level, and following that, if the potassium level is normal, then you can further, if it is on 20 milligram, we should try to maintain the dose on 20 milligram. Suppose you are uptitrating from 10 milligram and the serum potassium level is going up. If it is beyond 5, then we need to be cautious, and we can give some potassium binding regimens if the patient is having a persistent hyperkalemia, or else we can stop the molecule for a transient period, and again we can restart with 10 milligram and continue that same dose, sir. And the recommendation for checking the serum potassium level is that 1 month, 4 months following that. Every 4 months you need to check the serum potassium, sir.
How often you also determine GFR? Because the less GFR you can't give.
Yeah, actually, sir, maybe at least twice yearly we need to check the GFR, and depending on the GFR value, we can uptitrate or down regulate the dose of the molecule.
Achha. Now the subject is open for discussion. Any questions?
Just one question. Once you have started non-steroidal mRNA, and basically the GFR is somewhere around say 30 or so, and CKD is a stage 4 diabetic. Other than this SGLT2 inhibitors, and what would be the ideal diuretic? We know loop diuretics would be harmful, though they are on very often in our practice, but any other diuretic you would suggest, like a metolazone, or in addition to the SGLT2 inhibitors, in addition to probably insulin, and in addition to this finbrenon, anything in practice probably there is any recommendation, any particular diuretic which is safe?
Actually, sir, because of the CKD stage, we know that the patients are more prone to get hyperkalemia. So I think in that case, some potassium sparing molecules will be definitely better in this type of patients, because of as the GFR declines further, then there is higher possibility of hyperkalemia.
In general, we have seen prescriptions by nephrologists adding diuretics, They
sir,
exist.
even
In spite of all this, they have loop diuretics.
actually,
Though paradoxically, that also is harmful. It is nephrotoxic. So at that stage, how often you use metolazone and chlorthalidone at that stage? Finrenone.
sir, even there
Maybe
is
you just have to hike loop
Exactly,
diuretic
sir.
there. That's
Sir,
all.
even there are
Fine.
studies that are going on
Okay.
which are focusing on the effect of this phenomenon in patients with heart failure alone without any CKD. So they're going into that.
The only thing, one message just for the audience, that whenever you are treating cardiac failure, of course cardiac failure is not the topic here, but you did not go through any particular algorithm. You can straight away go to all the drugs in combination. That's the point. Thank you. Thank you, Dr.
Sir,
Hariwala.
sir, I should thank the people from Novo Nordisk and Sun Pharma for having me in this presentations. Thank you very much. Thank you, everybody.
Now, I would invite Dr. J.B. Kanwar, Professor J.B. Kanwar. He is the HOD in Department of Endocrinology, IMS and SAM Hospital, Bhubaneswar. To his credit, he has many published articles in peer-reviewed journals, written 4 book chapters and published 12 abstracts. He has been a reviewer of several journals, including IJEM, Founder Secretary, ODISHA Endocrine Society, Co-Organizing Secretary, SCCON 2018, Bhubaneswar, and he has been the Organizing and Scientific Secretary, Endocrine Society of Odisha 2016 and 2022. In fact, it's an interesting topic, a new molecule which has been in practice over the last few years, imeglimin, a novel insulin sensitizer that helps reversing pancreatic beta cell dysfunction. Let's see how far it reverses.
Thank you, Chairperson, sir. Very good afternoon to all of you. In the outset, I am thankful to RSSDI for having me here, particularly Dr. Jayant Panda. Today, I'll be speaking on a new topic, as Dr. Monty was saying, has been in the market for a few years. Before starting, I would ask a question. How many of you are using imeglimin? I think only 1, 2. How many? I think Dr. K.P. Tripathi was discussing about imeglimin, and he said me the many things I don't understand. How it acts, how it works, and where to place. Probably I would try to place this drug in managing hyperglycemia. So it's a novel insulin sensitizer that helps reversing pancreatic beta cell function. The topic has ideally been given this, you can understand it's both acts on insulin resistance as well as on insulin secretion. So before going into the details of, we do need to understand the biochemical structure. Most boring thing is the biochemical structure. Why somebody is taking, why this is a triazine compound. I'm not going into that. But just to focus on that, if you look at the structures, it has almost similar structures to metformin or fenformin. You can see the structures are all similar. So there must be some similarity in the mechanism of action because of the structural similarity in the side effect profile, and the action and physiological also. So, but this is a slight difference with the number of carbon atoms. I am not going into that. And now coming to the mechanism of action. We do understand most of the antidiabetic which we use, either they act on the insulin resistance and some act on the insulin secretion. Like if you use metformin, glitazones, they act on the insulin resistance, and some are like sulfonylureas, repaglinides, they act on the insulin secretion, DP4 inhibitor acts on the insulin secretion. But this is the medication, so anti-diabetic agents, which acts on both on reducing insulin resistance as well as increasing the insulin secretion. And it also targets 3 important target organs where the pathology of all diabetes is occurring, like liver, muscle, and pancreatic. So in the liver, it decreases the gluconeogenesis and glucose utilization, and muscles, improving insulin resistance, increases glucose utilization. And also at the similar time, in the pancreatic beta cell, it increases insulin secretion, and second important point, it inhibits the beta cell apoptosis. We have been looking for drugs which can reduce the beta cell apoptosis so that it reduces the progression of diabetes. Now, to understand the mechanism of this hemoglobin, we need to look into the mitochondrial structure. And this is a very complicated mitochondrial structure. You must have read this in physiology, must have forgotten. Just to say that everything is occurring in the inner mitochondrial. So many complexes are there, respiratory complexes, that the electrons goes out and the ATP is being formed. And hemoglobin primarily acts on these, modulates these complexes, complex 1, complex 2, complex 3. These respiratory chain complexes is being primarily being modulated by the hemoglobin. And if you look at the mitochondrial dysfunction, we do understand the multiple things are happening in the type 2 diabetes. It increases the SGLT2, it decreases the SGLT2 expression. So many things is happening. Similarly, the mitochondrial dysfunction is occurring like deficient oxidative phosphorylation. By deficient of oxidative phosphorylation, reduces ATP generation. Once the beta cell ATP generation is reduced, the less insulin is produced from the beta cell. There is excessive reactive oxygen species formation, and then an important aspect of beta cell apoptosis is mitochondrial permeability transition pores. If there is mitochondrial dysfunction in diabetes, these pores opens up. Once these pores opens up, then the apoptic protein comes to the matrix, and they start the process of apoptosis of the beta cells. So this kind of dysfunction is occurring in patients with type 2 diabetes. And how does hemoglobin help in that? Hemoglobin help in that by increasing acts on these multiple complexes. You can see that complex C1, complex C2, and C3. This is a primary site of hemoglobin action. And it actually increases the acyl dehydrogenase enzyme, which produces more acetic acid acetyl coenzyme, and acetyl coenzyme goes into the tricyclic pathway, and it transfers electrons through the C2 complex, respiratory chain complex. And this is a very important C2 complex that also inhibits, hemoglobin inhibits C1 complex. By inhibiting reverse electron transfer, it reduces reactive oxygen species. So if the C1 is activated, the more reactive oxygen species is formed. But hemoglobin acts on this C1 complex, reduces C1 complex, so it reduces the reactive oxygen species. And believe me, metformin is also acts on this complex, and it inhibits competitively and reduces the reactive oxygen species. So, and it also may have increase in the AMP kinase similar to metformin acting on this reducing this reactive oxygen species. And also, if you look at this is C2 complex, and if you look at the C3 complex, and that is involved in the formation or opening of these pores, the mitochondrial permeability pores. So, when the restoration of the C3 complex, that closes these pores, so the apoptic protein doesn't come out. So, and it also increases the multiple, the other metabolic pathway, through that it increases the NAD level in the pancreatic beta cell. So it increases the NAD level in the pancreatic beta cell, which causes the calcium release, leading to further insulin secretion. So if you just concentrate on the right hand side, that it improves beta cell function, beta cell protection as reducing the beta cell apoptosis, as well as insulin, enhancing insulin action in the liver and also muscle. So it's targeting almost the basic pathophysiology of diabetes, which we learn over the years is the primary two basic pathophysiology of hyperglycemia and type 2 diabetes. So whatever these problems with mitochondrial dysfunction in the type 2 diabetes has been addressed with the hemoglobin by improving ATP generation, reducing ROS formation, and preventing this opening of the mitochondrial permeability pores. Now let's understand what's the difference. Dr. Patra was asking me, so what is the difference between metformin, hemoglobin, and sulfonylureas? These slides that summarize the difference between this hemoglobin and metformin. As I mentioned, metformin inhibits only complex 1, and hemoglobin inhibits complex 1 as well as restores its complex 3. So restoration of the complex is also important for the closing of these opening of pores to reducing the apoptosis. And reactive oxygen species both being reduced by the metformin and hemoglobin, and amplify insulin secretion is not by insulin secretion is not only by sulfonylureas and with the hemoglobin. And it also improved the insulin sensitivity like the metformin. So there are some, because of the some structural similarity with the hemoglobin and metformin, so there is some action similarity. It's acting on these complexes, insulin resistance, and also the advantage over the metformin that is also causing insulin secretion. Now let's look into the clinical evidence. If you look at the clinical evidence, there is, I think slides are not clearly being projected, but there is a tremendous developmental program in phase 1, phase 2B programs, and whatever I said, this is acting on the these complexes, increasing insulin secretion, improving insulin resistance, has all been studied and seen in the preclinical studies in animal models in rate diabetic, rates with metabolic syndrome, where they have seen that it reduces, actually improving the beta cell apoptosis, and that has been shown to be in the rate metabolic model. They have shown that it improves the apoptosis, it reduces the apoptosis even compared to the GLP-1 receptor agonist. And they have also seen in the preclinical studies that improves insulin secretion even as compared to the sitagliptin as well as the repaglinide. And it also improves the phase 1 secretion of insulin, phase 2 secretion of insulin as compared to the sitagliptin. So many baseline program, as whether in the animal studies or whether in the phase 2 studies in hyperglycemic clamp studies, has clearly been shown that hemoglobin improving insulin secretion, hemoglobin reducing the beta cell apoptosis, as well as has also shown in the rat model, where they have biopsies, gastrocnemius muscle or soleus muscle, to look at the skeletal muscle insulin, improvement in the skeletal muscle insulin resistance. And finally, some clinical output has been, this has been approved in Japan after these 3 studies, times 1, times 2, and times 3, these studies, and it has been approved in Japan and China, and recently it has been approved by DCJ in India. If you look at the times program, the times 1, times 2, and times 3 program, where the hemoglobin has been compared with the placebo as a monotherapy in times 1 for 24 weeks given. And in times 2, hemoglobin has been seen as a monotherapy, has been seen also with the combination of other anti-diabetic agent. And in times 3, hemoglobin has, those patients who are on insulin, they have been given in hemoglobin has been compared with the placebo. So there is a good number of data of almost 1,100, 1,200 patients in time study to look at the safety, effectiveness of the hemoglobin as compared to the not only as a monotherapy, also with the combination of all the anti-diabetic therapy. I am going to show that to you. So this is times 1, the monotherapy trial. This is the first trial where the hemoglobin 1000 milligram twice daily has been compared with the placebo for 20 weeks. This is a randomized, a double-blind placebo-controlled trial. And you can see on your right-hand side, everybody reducing about 0.87%, almost 9% reduction in the HbA1c, and with a good safety profile. And this has also been shown in the phase 2B trials. So this is a monotherapy trial. And this is times 2 is where hemoglobin was seen as a monotherapy, how effective as a monotherapy, and along with the combination with other oral anti-diabetic agent, because they wanted to see where to place this hemoglobin, whether it can be given with other anti-diabetic therapy. And you can clearly see that if you look, hemoglobin has been added to DP4 inhibitor, thiazolidinediones, AGI, glinides, metformin, SGLT2 inhibitor, sulfonylureas, and GLP receptor agonist. So these are the anti-diabetic we are using in almost many of our patients routinely in our clinical practice. And if you see this diagram, that the first one, which shows that hemoglobin, when used with the DP4 inhibitor, there is a maximum HbA1c reduction, because primarily we do understand that DP4 inhibitor, DP4 inhibitor that acts on the GLP-1 receptor in the pancreas beta cell and causes insulin secretion. Similarly, we do understand with the metabolic improvement in the metabolic dysfunction, mitochondrial dysfunction, then imiglumin also improves the insulin secretion. So both have a different kind of mechanism of action of insulin secretion. So they are complementary in further increasing the secretion of the insulin. So it was obvious if you use imiglumin with DP4 inhibitor, then you are expect more likely to better HbA1c reduction as compared to other anti-diabetic agents. And has also been found to be effective in reducing the thiazolidinediones and as well as along with metformin and with other SGLT2 inhibitor. However, the GLP-1 receptor agonist on your right hand side, there is no improvement. If someone is on GLP-1 receptor agonist and you are using imiglumin, there is no further improvement in the HbA1c level. So I'll discuss that later on. Now coming to the very important thing of times 3 study, where these are long-standing diabetic Japanese patients, about 200 Japanese patients. The mean duration of diabetes was 13 years, and they have been on insulin, and they were randomized into 2 groups. One group was given imiglumin 1000 milligram twice daily, and other group was given placebo only. Then studied for this randomized double-blind study for 16 weeks. Initially, they looked into the 16 week, and they wanted to see what was the HbA1c reduction and the safety profile. Then after 16 weeks, for the next 36 weeks, they continued to give imiglumin to all the participants. So those who are receiving placebo in the initial 16 week, they are also randomized. They are all given imiglumin in the ensuing 36 week. And you can after 16 week, so imiglumin reduces HbA1c by about 0.6%. You might think 0.6%. What is the HbA1c reduction with the 0.6%? But remember that these are all long-standing diabetic patients with average duration of 13 years and has been on insulin. So you don't expect after that you give some anti-diabetic agent to reducing HbA1c further. But in this scenario also, there is further reduction of 0.6% with the imiglumin. So that's the take-home message from this study. And further after 36 weeks, when they looked into further reduction of imiglumin, in this 36 weeks time, all these patients, the placebo was stopped, all the patients were put on imiglumin. They found further reduction of 0.64%, and the end of the 1 year study, and patient continued to maintain HbA1c reduction of about 0.5%. So these are all long-standing diabetic patients on insulin, and they continue to have a persistent reduction of further reduction of mean reduction of about 0.5 to 0.6%. So just to summarize the amount of HbA1c reduction, because many people thought imiglumin is, which is mitochondrial energetics, it's not acting on the beta cell or insulin resistance, how much HbA1c it is going to reduce. Just this is the outcome of all the time study from times 1 to times 3. You can see the HbA1c reduction in the times 1 was about 0.7%. In times 2, where it was seen with other oral antidiabetic agents, it was 0.46%. In times 3, where it was used with insulin, HbA1c reduction was about 0.6%. So overall, about this time study has shown 0.6 to 0.7% HbA1c reduction. And in the number of people achieving the target HbA1c in times 1, where it was used as a monotherapy as compared to the placebo, almost 35% of the people achieved the target HbA1c of less than 7%, which you can see on your left-hand panel. And on the right-hand times 3, because these are already on insulin, so less number of people, maybe 7%, which is statistically significantly different with as compared to the placebo, achieving the target HbA1c level. Now, a very important aspect of imiglumin is how effective in the elderly population. And this is the sub-analysis of all these times trial, times 1, 2, 3. You can see the green bars that shows less than 65 years, and the lighter green bars or that shows more than 65 years old person. There's similar kind of HbA1c reduction in the times 1. But if you look at the times 2 and times 3, there is at least higher HbA1c reduction in the elderly population. So this is probably the message being given that many of the times we find it to choose an antidiabetic drug in elderly population. As you know, they must have comorbid conditions. They cannot tolerate many of the times metformin. Similarly, in this sub-analysis at least says that it is effective in reducing HbA1c in elderly population. And now another important aspect of chronic kidney disease, how effective in reducing HbA1c in chronic kidney disease. You can see all these times trial has shown that even the different grades of chronic kidney disease, you can see grade stage 1, stage 2 or stage 3, it has almost 0.5 to 0.8% reduction in the HbA1c. And the interesting study part of times 2 and times 3 study that almost 75% of the patients were in the stage 2 chronic kidney disease, and about 15 to 20% were having stage 3B chronic kidney disease. So this and in our clinical practice also, many of the times we see that diabetic patient having renal impairment, and probably hemoglobin is a good choice in elderly person with some chronic kidney disease or deranged renal parameter. Hemoglobin can be chosen in those patients. Now coming to the meta-analysis on hemoglobin, this was a recent meta-analysis just published last year. However, there has not been much data, as I was mentioning, is primarily being studied in Japan, and few of these studies done in the Caucasian population. And this is a meta-analysis by Dr. Uday Singh and Dr. Anup Misra, when they looked into only 2 studies, times 1 and times 2 study. They found that the HbA1c reduction is about 0.9%. And when they analyze further with 3 RCTs, the reason of using the 3 RCTs, there are also multiple publications were there, but these 3 RCTs being chosen because these were randomized and placebo-controlled studies. So that is the reason Dr. Uday choose these RCTs for meta-analysis, and here they found about 0.79% reduction in the HbA1c. So the result of this meta-analysis there, that as a monotherapy or in combination, it is effective in reducing HbA1c, and reduction of HbA1c is about 0.9% in monotherapy, is as par with currently available, which is used nowadays in our clinical practice, like DP4 inhibitor and SGLT2 inhibitor. And there is lots of talk about these medications, but they hardly reduces HbA1c by more than 0.7 to 0.9%. So, and the adverse effect profile in this meta-analysis they found is almost only with the GI side effects similar to the metformin, and this adverse effect profile was hemoglobin and placebo group were similar with slight increase in the GI side effect. And there has not been any lactic acidosis side effects have been reported in these studies. Just a last slide about the pharmacokinetics, that recommended is 1000 milligram twice daily, half-life was 13 hours. These are not metabolized. With renal impairment is more than 45 milliliter per minute, you give 1000 milligram twice daily, and 15 to 45 milligram. That is recommended by the Japanese body, about 500 milligram twice daily if the EGFR. But the DCGI doesn't allow to use with EGFR of less than 45. And where to use and how to use, that's the most important thing. Initially, when there is contraindications to other anti-diabetic, particularly elderly and renal insufficiency, and when there is side effects which are not, other anti-diabetics are not tolerated, or intensify is required, where other anti-diabetic has not been able to achieve the target HbA1c. To summarize, that decrease in beta cell apoptosis, hepatic gluconeogenesis, improves skeletal glucose uptake by the hemoglobin, and this targets 3 primary organ system affected by diabetes, and it can potentially be used as a monotherapy with combination with other anti-diabetic therapy. Thank you.
Professor Kanwar, now the floor is open for questions. Somebody, please.
I know many people would be interested to know about hemoglobin.
True.
Yes, yes, absolutely.
Diabetes control, fasting blood sugar, protein blood sugar, HbA1c, glycemic variability, and other comorbidities should be controlled. So far we are dealing with this molecule, promising role so far the glycemic variability is concerned. So any study, any work done in this respect in this molecule?
There has not been studies about the glycemic variability. If you compare hemoglobin with gliptins, DP4 inhibitor, both can be used at a time, with a combination of treatment for a better insulin secretion and better result and further HbA1c reduction of 0.9%. Glycemic variability is better. Obviously, with the sitagliptin, we do have data sitagliptin and vildagliptin reducing the glycemic variability. Do not have data about hemoglobin. So no problem if someone is on metformin and sitagliptin, HbA1c uncontrolled, mildly deranged renal function, elderly, no hesitation in adding hemoglobin in those patients also. But there is not studies with glycemic variability.
Sir, one excellent presentation, sir. Regarding, sir, one hemoglobin study is there. I am also part of that Dr. Prabhat Agrawal's group. So, but one on field, what we are seeing, sir, like as you told the molecular pharmacology that it almost superior to metformin. But in practice, we all know that metformin almost reduces 1.1 HbA1c. But in practice, hemoglobin only, sir, around 0.5, 0.6, that much reduction we are getting. And despite of 1000 mg twice in the current trial also. So that is the only concern. But it is a very safe drug.
Absolutely, it's a safe drug. Yes, Dr. KP.
Not say anything regarding renal modification. Why they have put a GFR of less than 45, it should not be used?
No. It is excreted unchanged in kidney. So there is no metabolites is involved. And they have found that those patients with having renal impairment, they are more likely to have GI side effects in patients with renal impairment. Otherwise, there is no reason of, that's why in Japan they have said that if it is 15 to 45, you reduce to 500 twice daily only for the compliance or reduce the side effect profile so the patient can tolerate better and not for the HbA1c reduction or not for any other things. But DCGI as for some other reason I do not know, they have mentioned that in India because of data are lacking with less than 45, so you should avoid using in less than 45. I think that can be modified once the more Indian data are available that the study is being done with the 15 to 45 ml, then they would modify later on also.
And one more, being a clinician, we would always like to see that when patient is not tolerating metformin, we search for alternatives. Can we think that hemoglobin can be started if someone is not, tolerating metformin because of GI side effects?
You are correct, but for as a physician, you know, if someone is not tolerating metformin, there are multiple other options are available. So, in placing hemoglobin, even I speaking about the hemoglobin, placing hemoglobin if someone is not tolerating metformin before SGLT2 inhibitor or DP4 inhibitor won't be a practical idea. So once we know, more knowledge comes through, then probably other good effect, like it has studies in rate metabolic syndrome. Patient with rate metabolic syndrome, they have found that it improves the cardiac function. It improves the age-related enlargement of the diastolic or systolic volume of the heart. It improves the LV systolic function in metabolic syndrome. So there may be some scenario in patient with metabolic syndrome where you want to give metformin because of impaired glucose tolerance. In those scenarios, probably imiglumin is a more preferred option than metformin even. So this is in the preclinical studies only. So more data we need to see in human, say that it is also, it's a good drug in the metabolic syndrome also.
Anybody else?
How prudent is to continue metformin? If somebody is on metformin and you are adding imiglumin, then I mean both the drugs have almost similar mode of action, similar function. So why to continue metformin? Then you can stop metformin and continue imiglumin.
We do understand that metformin is not only acting on the respiratory complex, it has also effect on the AMP kinase, and AMP kinase also involved in the neuronal protection because metformin being tried in the Alzheimer's disease, Parkinson's protection. So many good effects of metformin are there. Why would you like to stop that? Why not to use metformin along with the imiglumin? So I would not say to stop metformin and start, and metformin cost about 1 to 2 rupees with multiple pathophysiological mechanism. Even we do not understand the other mechanism how metformin is working many of the times. So many good things being done with the metformin with 2 rupees tablet. So why you want to stop it? Rather you continue with the metformin and add a imiglumin.
One last comment, maybe a comment or a question for you. In fact, since 2006, after the rosiglitazone was taken off because of its side effects and all, US FDA made it a point that every diabetic new molecule has to go through the cardio-renal benefit. If you talk from that perspective, then this drug probably has not gone through that from the US point of view. That is why USA practitioners, they are not too much in favor of this molecule. It came from Japan and it is now in India. So it's up to the audience to exercise their wisdom that if something has to be taken from the perspective of cardio-renal benefit, probably this is not the right molecule, which has come recently. But if you talk in terms of a replacement for metformin, maybe this can be considered. And various trials have gone up to 6,000 milligram, which I was referring a little bit. Maybe the ideal choice is probably 1,000 milligram twice daily, or maybe 1,500.
They tried with 500 twice daily,
yes.
1,000, 1,500 and 2,000 twice daily. They have found out the HbA1c reduction with 1,000 is 0.94 and with 1,500 twice daily reduction is 1%. So just a 0.06
so I think it is already with a higher side effect. And people are in a hurry. So thank you, Professor Kanwar, for all this enlightenment. Thank you.
I request all the faculties and chairpersons to move to the dais, memento dais, to collect their mementos. The chairpersons for the next sessions are Dr. Ashok Kumar Mahanti, who is a senior diabetologist and family physician from Bhubaneswar. Dr. Surjit Kumar Patra, is he there? No. Then Dr. Debidat Pradhan, who is a consultant diabetologist and geriatrician from Cuttack. And Dr. Ashok Kumar Behera, who is Associate Professor of Medicine and in charge HOD of Sant Bhimibhoi Medical College, Bolangir. The session is over to you.
Good afternoon, and all are hungry for the food. But before going to food, we will discuss. Well, I will call upon the speaker is Dr. Otanu Thakur, and he is the Associate Professor of Medicine in Bhimsar Burla. He is the member of API and IRA ODISHA. He has completed the certificate course in diabetes from Joslin Diabetes, Levaland Diabetes. Everybody is more interested for the complications and its treatment, but he will say the basic things, that is the pathogenesis of complications of type 2 diabetes. So without wasting much time, Dr. Thakur, you can start.
Thank you, Chairpersons. I thank Professor Jayant Panda sir, Dr. Santosh, Dr. Goenka sir, to giving me a chance to speak on this in front of this illustrious esteemed audience. And as a lunch time, I will try to finish this early, and it is a more at the molecular level, so I try to be fast and finish it early. So as the content of the talks go like this: introduction, overview of the diabetes and its complications, emerging complications, and the separate different newer pathways of the complication of diabetes, the factors involving pathogenesis and complication of diabetes, importance of understanding the newer pathways, and the trials undergoing the newer pathway with therapeutic interventions regarding reduction of these complications. So at the start of the talk, we should go along with the study published by B. Mohan sir, and he stated the burden of the complication of diabetes in a larger cohort group, and the prevalence of both macro and microvascular complications was very high, and neuropathy was the most common complications, followed by the cardiovascular, renal, and the ophthalmological complications. Food ulcer was 5.1% of this, all the samples they were taken. So increasingly, as the HbA1c target is not being achieved, in spite of so many methods and interventions with so many pathogenetic mechanisms, with all the drugs, with combination therapy, with insulin, we are still trying to achieve the HbA1c target of 7 as for the ADA-AST guidelines, and there is more and more complications are coming. So simply classifying the diabetes complications are acute and the chronic. And the acute complications, as you all know, are hypoglycemia, diabetic ketoacidosis, HHS, and the chronic complications are long-term microvascular and macrovascular complications, where we have in the microvascular complication retinopathy, neuropathy, and nephropathy, and the cardiovascular, cerebrovascular accidents, and peripheral arterial disease are included in the macrovascular complications. The chronic complication of diabetes are generally due to, we thought that is because of the insulin deficiency or insulin resistance, in combination with persistent hyperglycemia and dyslipidemia and disorders of the other metabolic pathways. The other complications that we normally do not include in these macro and microvascular complications are the cognitive dysfunctions, increased risk of certain malignancies like the GI malignancies, genitourinary malignancies in females, and periodontitis, and there is poor wound healing, and there is very discordant viral and bacterial infections in the diabetic as for the outcome with the normal population is concerned. And the conventional classification need to be revised, since there are many complications of diabetes that cannot be easily or correctly placed only in micro and microvascular complications. So this is established fact that metabolites from hyperglycemia and loss of insulin effect associated with diabetes can induce cellular changes in parenchymal tissues. It has been established despite a normal vascular functions. In spite of a normal vascular functions, there are parenchymal changes, and this is in insulin defect, and it has been established. Now, the traditional studies on the pathogenesis of complication of diabetes have largely focused on risk factors such as the hyperglycemia or the oxidative stress, inflammations, and because of the AGE, the advanced glycation end products, and activation of the stress kinases and protein kinase. The vascular and neural systems are clearly important in development of many complications of diabetes, since they connect and they are responsible for the signal transductions. Now, there is a interplay of risk factors and protective factors in development of chronic complication diabetes. Several studies has illustrated that there are certain risk factors and the local protective factors, and there is an outplay between the two, and that decides on the long term which organ is to be damaged in the long term complication diabetes, and if the protective factors are more prevalent, then these organs are saved. So the hyperglycemia is significant for initiation development of the retinopathy, neuropathy, and the nephropathy, although other systemic factors such as the hypertension, insulin resistance may also contribute to as well. So in addition to the systemic factors, tissue-specific risk factors have also been observed in certain studies employing the transcriptomics, metabolomics, and metabolic flux. The metabolic flux denotes the excretional level of these end products of the metabolic process, and they found out that in glucose and lipid metabolism in the kidney, eye, and nerve, the metabolic products are altered, and they actually triggers in certain, and it triggers certain the signal pathways and cause the inflammations. And there is a more definitive study that has concluded that in type 1, type 2 diabetes, the chronic hyperglycemia causes subclinical myocardial injury, and this leads to a leakage and the exposure of the cardiomyocytes, including the alpha myosin, to the immune system. So the immune systems are triggered, and there are certain antibodies are being formed, and it is more prevalent in type 1 diabetes, they have found, and also in some type 2 diabetes. So also, and it is an established fact that at the end of the TCA cycle, the metabolites fumarate that may be involved in pathophysiological pathway of independently risking the kidney, and this is separate from the cardiorenal risk factors. That means fumarate has independent actions on these nephropathy process. So the major traditional complications and emerging complications of diabetes, the diabetes kidney disease, retinopathy, peripheral neuropathy, then the CAD, cerebrovascular accidents, and peripheral vascular disease. Now the emerging complications like the more chances of malignancies, outcome of the infections, and more chances of the infections, the liver diseases in the form of MAFLD, then functional disabilities, cognitive disabilities in the form of dementia, affective thought disorders. These are all other complications that we normally do not take into account, and the pathogenesis process are different slightly from the vascular complications. Now, the chronic complications of diabetes are due to myriad of disorders of numerous the metabolic pathways. The triggering factors is hyperglycemia, or dyslipidemia, and hypertension. And there are certain systemic tissue specific protective factors like the increased glycolytic flux. There is mitochondrial enhancement of the mitochondrial functions. We recently just listened about the mitochondrial dysfunctions. And there is more of these antioxidant enzymes, the superoxide dismutase and the dehydrogenase. So the anti-inflammatory cytokines and factors mostly is the nitric oxides, and the cytokines, those are anti-inflammatory, are IL-4, IL-1, and IL-10. They protect the local tissues from the inflammations. And also the vascular endothelial growth factors, the VEGF, platelet-derived growth factors, incretins, and retinol binding proteins. These are the local proteins. They try to save the organs in spite of the risk factors. Retinol binding protein is recently been studied very largely, and there was a study called the Medalist study where the complications of retinopathy in certain group of the samples were not there correlating with the high HbA1c. Though they had a more high HbA1c, the PDR and NPDR were not formed. And certainly later on they found out that the retinol binding protein 3 level were very high in those group of samples. And this retinol binding protein later on found out to be the counter-regulating protein that actually save the vessels which are formed by the neovascularizations by the VEGF excessive expressions. So the VEGF is the main culprit while the retinopathy is concerned, where it causes the neovascularizations, and there is a the endothelial disruptions in the neovascularization process that later on causes the hemorrhage and cause the PDR. So this process is protected by the retinol binding protein 3. Now the systemic tissue specific risk factors are the reactive oxygen species, nucleofactor kappa B, this is pro-inflammatory, stress kinase, protein kinases, and also AGE, more of the AGE, and also fibrotic and the vasoactive cytokines. So both these, the risk and the protective factors, ultimately they change the local vasculatures and can also decide on the complications of the parenchymal complications. Now the chronic complications from diabetes are due to myriad disorders. Chronic complications should be reclassified using the macro and microvascular category to the vascular parenchyma and hybrid combination of complications. Now the pathogenesis of diabetes complication often involves the interplay between the systemic and the tissue-specific risk factors. Endogenous protective responses may help in explaining the differential severity of the diabetes, and there are certain individuals where in the long-standing diabetes do not have complications, where other individuals in the very short form, short time of diabetes, they develop the complications. Why the disparity? And this probably is explained by the local anti-inflammatory proteins that has been produced and save the organs. So these protected individuals are to be more studied, and the region behind the protected individuals should be analyzed. So this is the vascular and the vascular parenchyma mix and the parenchyma tissue disease. The vascular, we know there is enhanced atherosclerosis, there is foam cell formations, and then it triggers the inflammations and apoptosis and thrombus formations. In the vascular parenchyma mix are the PAD, the peripheral vascular disease, where there is a fibroblast growth, and the angiogenesis in PAD is not there in spite of there is a tissue hypoxemia. This is a disparity of the VEGF. The VEGF is expressed more in the eye by the hypoxic process, but the VEGF is not downregulated in PAD in spite of the local tissue ischemia. So there is a disparity of the VEGF actions on the angiogenesis, and that is separate in eye and separate in the PAD. So wound healing is absolutely a vascular and parenchyma mixed phenomenon. Neuropathy, nephropathy, where the mesangial expansions, the glomerular basement membrane thickening, these are the parenchymal disease contributions, and there is peritubular, the vessels fibrosis are the vascular phenomenon in nephropathy. In eye, it is parasite, which is a parenchymal concept, and also the neovascularizations with the vascular phenomenon in ophthalmological complications. Now, there is proliferation of mutated and dysplastic cells, and more chances of these gastrointestinal and the genitourinary cancers in diabetes, and this is purely a parenchymal phenomenon. The CNS injury in the form of amyloid plaque deposits in Alzheimer's, these are the parenchymal tissue complications. So we should now differentiate between the vascular and also the parenchymal complications. So there is a vascular wall and parenchymal tissue where the risk factors are there, the protective factors are there, and there is an interplay. And the outcome of the interplay decides whether the organ is to be, when it is to be affected, and how early it is to be affected or not affected at all. So these are the systemic protective factors identified in different experimental studies, and this includes the insulin, the IGF-1 and 2, the fibroblastic growth factors, platelet-derived growth factors, the vascular endothelial growth factors, and the tissue growth factor beta. High-density lipoproteins, vitamins, mostly C, D, N, these are antioxidants, and the antioxidant enzymes, the glutathione peroxidase and the superoxide dismutase. Then there are cytokines which are anti-inflammatory, IL-4, IL-10, and IL-13. They're anti-AGE products, those who are protective. Then activated protein C, these are the protective factors at the systemic level. At the tissue level, it is IGF-1 and 2 retinal binding protein, as I discussed, that saves the eye in certain individuals. The platelet-derived growth factors, nitric oxide is a vasodilator. More expression of the nitric oxides reduces the vascular insufficiency. VEGF is important. There is very disparate expression of the VEGF gene in certain organs and not in certain organs, and it is a dual mode of actions. Now, tissue-specific factors, there is local protective factors help counteract the harmful effect of hyperglycemia insulin resistance. Now, the key system in defense in the KIF, the nuclear factor 2 pathway, where toxin cause the dissociation of the KIF from the NRP2 and allowing the NRP2 to move. This is a protein that moves to the nucleus and induces antioxidative, antitoxin enzymes expressions. So, the nuclear factor 2 protein is a protective form of peptides that helps to protect the local tissue. Now, this is a disruption of cellular signaling pathway by the risk factors, and you can see there is more of the. So, when there is more of the hyperglycemia and this glycolytic process is enhanced, also there is, when there is more free fatty acids, the fatty acid binding proteins incorporated to the cellular level, there is more glycolysis and the more of the beta oxidations, and the beta oxidation produces the diacylglycerol, which enhances the PKs and stress kinase, and there is more phosphatase, and these are protected by the insulin-like growth factors, but this triggers the inflammatory cytokines release and more of the inflammations. And increase of the glycolysis causes the mitochondrial dysfunction, discordant mitochondrial functions, and that release more of this nuclear factor kappa B and more of the DNA damage at the nucleus level, and that enhances the apoptosis. So the dual role of the TGF-beta diabetes-associated fibrosis and implication for targeted therapy. Now, TGF-beta is local factors that are elevated in tissue affected by diabetes and linked to fibrosis-related complications like diabetic nephropathy mostly, and also the myocardial dysfunctions. Hyperglycemia increases the oxidative stress, inflammatory cytokines, and the protein kinase C activations, which induces TGF-beta expressions and contribute to cellular hypertrophy, extracellular, the matrix biosynthesis, and leading to fibrosis. Now, neutralizing the TGF-beta with monoclonal antibody in mice have improved glomerulosclerosis and delayed renal functions impairment, but did not affect the urinary albumin excretions. If you counteract the TGF-beta, the glomerulosclerosis is delayed, but the proteinuria is not improved. So insulin has a dual role in vascular tissue, possibly by the protective role of insulin, and also there is hyperinsulinemia that triggers the inflammatory process. So insulin acts through two pathways. One is first is the PI3K AKT pathway, and the other is the SRC-MAKP cascade. And here it is pro-inflammatory. This pathway is anti-inflammatory, and this is more of these inflammatory cascades are triggered with this pathway. Now, insulin also processes proliferative mitogenic actions, and this is mostly mediated by the SRC-MPK pathway, and that causes more of the mitogenesis. And the mitogenic action of insulin have been associated mostly with adverse consequences, including atherosclerosis, fibrosis, and the thrombosis. Now, here there is the protective function of the insulin, and this is by the MPK pathway and the PI3K pathway, and there is more of the DNA repair, and these are the risk factors which enhances the inflammation and then counter-regulated by the protective mechanisms of insulin. VEGF, I have already discussed. Now, retinopathy, the most important thing is at this level of severe and moderate NPDR, the progression of full-blown retinopathy is by the VEGF, and it is counter-regulated by the retinal binding protein 3. Now, I thought the most important part of the nephropathy is the leukocyte recruitment process by the activation of the intercellular signaling pathways, and that viciously affects the nephropathy process. Now, there are several, I will conclude very fast. There are several therapeutic intervention has been tried in mice models with these receptors level, and some of them are the phase 2 trials to reduce the nephropathy process and addressing the inflammation. Cardiovascular complication, as we know, and it is also atherosclerotic cardiovascular and also
Dr.
the
Thakur,
cardiomyocyte
be fast.
dysfunctions. Yes. So concluding, systemic tissue-specific risk factors prevent and reduce complication in diabetes, establish role of insulin, growth factors, and antioxidant pathway, novel protective role of the RBP3 in diabetic retinopathy has been established. New drug like SGLT2 and GLP receptor agonists offer increased therapeutic options indicating unknown protective pathways, and despite scientific progress, challenges remain in the study in chronic complication of diabetes and need for extensive study to identify few protective pathway, understand existing one. Thank you.
Thank you, Dr. Thakur, for your nice and elaborate presentation. We will take the question after the session is over, as we are running lack of time.
Thank you, Chairperson.
Now we have a dynamic and energetic, eloquent speaker who is always smiling, and he is Professor Sikanta Kumar Dhar. He is the HOD medicine in the IMS Some Hospital and Some Ultimate. There are many accolades, but at least he has RSSDI National Award 22 and IMJ Youth Icon Award 22. And now I request him to discuss about the artificial sweetness.
Thank you, sir, for the nice word. Thank you, Professor Panda, for giving me opportunity. Although late in the afternoon, because everybody busy with adding calories, I am here to de-add your calories. We are de-diabetes India. We are de-calorifying you. So my topic is, please. My topic is artificial sweetener, whether to use or not. Next. Artificial sweeteners in diabetics, use or not to use. This heading has not been given to me. My topic is here to the safety concern. But before I start about the lunch, which the people has, Swasti Beach Resort has presented, can you use your mind? Dimag ki batti jalao. How much calorie you are using now? These people, those who are using outside. Any guess? 400. Oh, 4, more than 1200, you are right. So we are adding calories, but what is our message to the society? But our message to the society is eat healthy food, but we are actually not taking. So I am there to make you healthy. But do you know how India is eating? This is a Times of India paper. You can see how much people. United stores per day per store, 381 pizza, 700 per KFC bar. This is the old paper cutting. So you can know what will be data. This is 21 now in 24. So what we are doing malnutrition to malnutrition. So Indians have a sweet tooth. You know, most popular sweetener in the world, sugar, invented in India. Sugarcane cultivation in culture, the Atharva Veda says. Even Jagannath culture is also advocates it. Sugar production, we are second in world. Sweet consumption is the highest in world. We are producing second, but we are taking in the highest. So my topic is artificial sweetener, and I am saying about this, the pros and cons. Artificial sweetener have become an alternative to sugar. That is why this is important nowadays. Whether we use it or not in diabetic patients is important. Increased incidence of obesity, diabetes, and metabolic syndrome, coupled with heightened consumer awareness, has led to a steady paradigm shift towards the use of low-calorie artificial sweetener. That is why this has been used so much. Now you can see the history of non-nutritive. This is not new. 1931, the first stevia they have used. But nowadays we are getting many agents. The fun fact is saccharin, the aspartame, the sucralose is discovered accidentally. So these accidental products have now become incidental and are using very frequently. What are the types? They have got a family of starch-based, saccharides, sugar alcohol, and non-nutritive acids. I'll be talking more about non-nutritive agents. The intense sweeteners. Why intense? They are almost 200 to 600 times or almost 3000 times sweetener that the sugar our taste bud cannot determine. They are available in tablet, liquid, and granulated form. Artificial sweeteners approved by FDA. They are not approved. They are approved by US FDA These are all that we are using day in and day out. They are being approved by US FDA. What are the approved in India? Food Safety and Standard Authority, FSSAI approved aspartame, acetylpen, saccharin, sucralose, whatever you are taking every day are with this type of NNS. Most commonly used product in India, you will be knowing about sugar-free gold and sugar-free natural. This is not a sponsored slide. So you can say the aspartame and sucralose are the most common used. What is the need of NNS? Data shows that increasing sugar consumption, I already mentioned, we are the topper. As per WHO, are not getting a gold in Olympics, but we are topper in so many things. As per WHO 2015, there is a strong recommendation to reduce intake of free sugar to less than 70%, to less than 55% of total energy, if you are having some other comorbidity. So this is essential to reduce your calorie, which we are showing in my first slide. So Indians are high risk of developing obesity. We are different. Like the tomato ketchup, we are different always because of high obesity, high metabolic syndrome, high diabetes, and there should be a restriction of free sugar intake crucial. So what should be the ideal NNS should be like? It should be like, it should be no unpleasant aftertaste, have little or no calories because it is sugar free, no calorie free, it should be calorie free, not have any side effect, commercially economically viable, able to survive cooking. So it can be used in cooking. What are the low calorie NNA? Non-nutritive low calorie substance used for sweetening, interact with the taste receptor to give a sense of sweetness, much sweeter than sucralose, and can exceed sweetness of sucralose by 30 to 37,000 times. This is that much sweet. But the key characteristic of non-nutritive sweetener, you can see so many agents which I have already mentioned, those are being, they are all calorie free. Or you can say the negligible calorie you are adding to your diet if you are using. What you can see, the times they are using. The acetylpen is around 200 times, neotem around 13,000 times sweeter. The test board cannot determine what you are taking. Aspartame, the first generation, not going to say much about the, as per the data, 40 milligram per kg per day, which you are not taking. About what are the agents which are using with this aspartame in India and all, Coke, equivalent, these powders you have seen in your room. So these are the powders, and what the medicine you are taking, the drugs you are taking, the tabletop sweeteners, the chewing gum, the chocolates you are taking, they are using this. So they are not adding calories per se, not adding much of sugar. They are diabetic friendly, as the data says. I will say later on. Similar taste to sugar, small amount needed for a sweet taste, enhances and extends flavor. That is why they are adding here. Now, what are the disadvantages of aspartame? Not stable at high temperature, not proven safe for children, so it should not be used, but data says something else. I will say. Contains methanol, which can affect vision, but it is controversial. So there is a controversial. The another agent, the first generation, which I am saying, 15 milligram per kg per day. Another agent, sucralose, which are using almost daily. You can see it is again 15 milligram per kg per. You can see that it is extensively used and it extensively studied. Not that the studies are almost 110 studies have been done and safety concern has been determined, and it is US FDA approved as well. Now what about steviol, which is new, not new in the market, but newly they are propagating. The calorie value is almost zero. The calorie value zero. The acceptable daily intake is 4 milligram of steviol equivalent. So I'll be saying in my last slide how much you are taking and what is approved. Neotem, the third generation, it is a same, but the acceptable daily is 2 milligram per. And even it is approved in 40 countries. Almost all others are approved in more than 100 countries. Now, the last but not the least is whether they are safe or not safe. Question asked, what are the questions coming to your mind? Will they cause obesity? Some papers say they called obesity. Now, will they cause increase in insulin resistance and affect glucose metabolism per se? Will reduce endogenous GLP-1 and GIP secretion? And whether they have a cancer. These questions come to mind whenever all people come to your clinic and they say they can induce cancer. Now what the study says, are artificial sweeteners totally safe? Most artificial sweeteners are not metabolized in the body and so are generally considered safe for consumption. Toxicity of non-metabolized compound is always a concern because they are found in animal study. Cyclamate banned in 1970 due to suspicious carcinogenesis, but I will saying then later on they have found to be, these are safe. But I say there are only animal study, no human data yet. Now what are the preclinical study? You can see the artificial sweetener include glucose intolerance by altering gut microbiome. These were the studies that was published earlier, 2014. But later on, there was evidence-based reality. Long-term study in UK demonstrated link between consuming 2 or more servings of artificial sweetener, risk of containing diet, soft drinks, increase the risk of coronary heart disease and chronic kidney disease in comparison to consuming less than serving. If you take 2, there might be more chances. But again, it has been compelled by another study. There are other studies, recently 2 different studies with aspartame and sucralose showed their independent potential to rise the blood glucose and insulin level. So, but effects are again not very fruitful. The benefits of using artificial sweeteners in obesity are often offset by phenomena of compensation, ingesting calorie later to compensate for energy. So there has been confusion whether they are safe or not. Role in diabetes, again there is a question. 7 observational studies dealing with this consumption and incidence of type 2 diabetes showed diverging results. So there is not proof. But cohort studies of good quality, 3 undertaken in North America population, 1 in European population, over a period of 9 to 24 years did not show any relationship between the consumption of artificial sweetened beverage and risk of developing type 2. So nowadays they are saying there is no increase in HbA1c after you take this NHS, after adjustment of BMI and energy intake. So there are some Indian study also I will be depicting. Role in diabetics, I have already mentioned. Nowadays they say that the French study almost showed that the incidence of type 2 was significantly higher, 2.21. The second study undertaken in United States, 7 years, reported increase in incidence of type. So the studies are very not very favoring. Third study which reported increased incidence of type 2 in consuming more than 1 artificial sweetened beverage per week, T1.7. So incidence is higher in few studies, whereas some studies are neutral. It is important to underline the heterogeneity of these data, particularly in terms of the characteristics of population and the monitoring period. From 7 to 24, they have checked it, but recent data, recent 2 to 3 year data, they are saying that it is safe. Furthermore, in these studies, the consumption of artificially sweetened beverage was recorded when the subjects were first included upon through self-administered frequency. The frequency is not very categorized, so these studies don't validate. Whether this artificial sweetener used susceptible population, yes, widely used every day in a variety of food like cosmetics you are using and dietary products you are using. So we don't know what is their effect. Caution must be raised in certain high-risk individuals such as pregnant and lactating. No much of data there, but they are saying it is safe. Diabetics, migraine and epilepsy patient. You should use it in caution. Children are especially important because they have higher food and beverage intake per kilogram or kg body weight. Because everything I have said in per kilogram, so there should be some restriction in the children's. However, if you see the Indian data, recently published 4 days back, you can find in paper, this is the Indian data by our great V. Mohan from Madras Medical Study. Artificial sweetener sucralose in your tea, coffee is safe. New study shows. So there was no Indian data per se. I was saying about European and USA data. These are data recently published, about 3 to 4 months of data. They have taken 200 patients. And they have found that it is not increasing any HbA1c. There is weight reduction of 0.5 kg and there is waist circumference reduction. They are saying that this is favorable for Indian patients. What they have used, they have taken 1 to 2 servings, means they have used it in sugar, in tea. So 60 kilocalorie they say they have refreshed. So you can say this is safe to some extent if you use in a lower amount. What law I will be discussing. Whether the last question, whether there is a cancer list. Artificial sweeteners and cancer resulted from nutrient, the population cohort study. They said that they compared to non-consumers, above the median exposure in consumer had higher risk of overall cancer. Initially they were thinking. But other studies, like meta-analysis, do they have carcinogenic study? The possible risks of artificial sweetener to introduce cancer seem to be negligible. So further studies say that there is negligible incidence. So this topic is almost over. You can say your patient that the cancer risk is negligible. Increased appetite, weight gain, and risk of metabolic syndrome. Yes, there is, we have already mentioned that HbA1c is not increasing. No harmful effect on metabolic parameter. You can see this is a meta-analysis. There is no the statistical significance, no statistical. So this much of meta-analysis they have shown, and you can see the RCTs also. They are saying that there is no harmful effect on metabolic parameter. So you can safely use in your patients with diabetes and other metabolic derangement. So the effect of low-calorie sweeteners on energy intake and body weight, a systemic preview, you can see studies comparing the efficacy of sucrose and NSAIDs found greater reduction in body weight. I have seen in Indian data, Dr. B. Mohan, they say that 0.5 kg reduction and more significant reduction in energy intake in the group NNS. So they have found it is beneficial weight reduction. Now what I am saying, you can see there are so many randomized controlled trials, they find that there is no statistical significance. There is no weight gain per se, so, but there is weight loss. So this is beneficial. But what is the maximum amount? I have already mentioned what is the dose we can take. You can see what is the maximum. 155 pellets per day is the acceptable daily intake of aspartame. That is 45 milligram of kg of the tablet. If you take 155 pellets per day, tentatively in a day, then probably it may cause some problem. Probably not advising our patient to take 1 to 2. What WHO has said that don't take it for obesity purpose or weight reduction purpose, where you can use more for any use. So 1 to 2 tablet, 4 tablet is almost safe for me or maybe for you, because these are the levels which are not using. You see the advantage, acceptable daily intake, this much of doses you can advocate. So these are safe to say me. If you say me at the end, what I will say, these are safe to our person. Whether it is safe for all patients, almost safe. It is safe, but the US FDA has approved in pregnancy, lactation, children, dyslipidemia, diabetes, reactive hypoglycemia, and dental caries. Earlier they were saying that they were producing dental caries, now this is free, the new agents, so they said it can be saved in dental. What we don't know about this, there is no much of studies. As I have said, there is first Indian study, what I could find, Dr. B. Mohan has produced this in only 200 cases. So we need more studies. We request RSSDI to put forward much brain to use in our patients so that can extrapolate our data and our patients, how do they behave, because they are used in Madras. Create adequate awareness between people, develop guidelines for the use of NNS, we should go for this to address effectively, safety concerns, because still ways ahead to know the safety and to generate safety data by RCT. I have put forward so many RCTs, but all are European and USA data. So at the end, I will say that these are safe to some extent if you use in a lower dose, and you are the best judge for your patient how much to use. Thank you again for the patient hearing.
Thank you, Professor Dhar. You have finished it before time. Everybody is hungry. Thank you very much.
Thank you, sir.
Later on, we will take up the cases during the lunch.
The next topic to be discussed is emerging novel clusters in type 2 diabetes mellitus. Its diagnostic and therapeutic ramification. And the speaker will be Dr. Philips Rautray. His achievement is he has 4 original articles in peer-reviewed journals. He was previously at Mohan's Diabetic Center, and he has 10 years of experience that place. And now he is Chief Consultant Diabetologist at Mohan's Diabetic Center in Bhubaneswar. So the stage is now of Dr. Philips.
So thank you, respected chairperson, for the kind word of introduction. At the outset, I must thank RSSDI, the organizing secretary, and the scientific committee, Jayant sir, Santosh bhai, Hariballabh bhai, everybody, my seniors, for giving me this opportunity. I know I am the last batsman in this tournament. So I'll try my best to make it interesting. This is an offbeat chapter kind of thing. you can say is a newer one, the emerging novel clusters in type 2 diabetes and its diagnostic and therapeutic ramifications. Now I have no conflicts of interest. The big question. So I'll start my talk with the simple definition that diabetes is a heterogeneous condition characterized by chronic hyperglycemia, which is because of the disturbance in the metabolism of protein, fat, and carbohydrate, is because either the secretory defect of the insulin or its action or both. But the big question is, are all type 2 diabetes the same? Why I said type 2? Because more than 90% of our diabetic patients, they belong to type 2 diabetes, and rest are type 1 or LADA or MODI or something else or GDM. So the question is, are all type 2 diabetes the same? Because the current, what we are giving, the treatment, the diagnosis, we are treating diabetes as a homogeneous condition. But is it the correct one? Of course not, because we are seeing many patients, many differences in type 2 diabetes patient, the variability by the BMI, the age of onset, the response to medications, and also susceptible to complication. As you know, few patients, they respond better to metformin, some better to sulfonylurea, some better to DPP-4 or even SGLT2 inhibitors. Some respond to early in the course of diabetes, they respond very well to the insulin, some in the late, and the complication. Many patients we have seen even after 10, 12, 15 years of diabetes, they have very low chances of getting complication, whereas the other people within even young diabetic patient, 30 years, 35 years, even within 1 to 2 years of diabetes, they have developed retinopathy or nephropathy. So why this so? So is it prudent to treat clusters in type 2 diabetes to say each characteristic of the individual clusters? The said they are early onset of diabetes related to low BMI, they are GAD positive, they are less diabetic type 1 diabetes. The sick or the severe insulin deficit, similarly they are early onset related to low BMI, but importantly they are GAD negative. The said is GAD positive, so type 1, and this is also have like type 1, but they are GAD negative. The ammonic mild obesity related, and the last one is mild age related diabetes. Now the question is, can this be applied to Asian Indian population? Because we know that the Scandinavian population is the white Caucasian population. Whether the same cluster can be applied to the Asian Indian population. The question, why I put this question, because we know the Asian Indians are different in many aspects. In the sense we are having diabetes and high from our database, from our hospitals, from our database, from more than 50 centers, that we have more than 19,000 individuals with type 2 diabetes aging between 97 years with a duration of diabetes less than 5 years. We have conducted a study, but here instead of 5 to 6 variables, we have taken 8 variables, which includes the age and diagnosis, BMI, waist circumference, HbA1c, serum triglyceride, HDL cholesterol, C-peptide, both fasting and the stimulator. We have taken 8 variables. Now, this is the result what we found. In the Scandinavian population, we have found 5 sub-clusters, but in Indian population, we have found 4 clusters. Out of that, 2 are being same, which are being seen in the Scandinavian population. One is the SID, that is the severe insulin deficient diabetes, and the MARD, the mild age-related diabetes. But what we found, the new thing, 2 new clusters, which we have termed the novel clusters in the diabetes, that the IROD, that is the insulin-resistant obese diabetes, and the SERD, that is the both combined insulin resistance and deficient diabetes. What we found, the characteristic, the SID, same thing like the Scandinavian population, early onset diabetes, relatively low BMI and low waist circumference, both low beta, HOMA beta and HOMA IR, and low C-peptide. In the MARD, other hand, just like the Scandinavian population, older than the patient in other cluster, nearly the age after 50 years, with the highest level of HDL and fairly preserved C-peptide. Out of these all 4 clusters, the maximum number of population that belong to this MARD group. And these are the best group in the sense in the management of the diabetes. They are having very mild diabetes, easy to control. They are having very low risk of complication. But the 2 new subgroups or the novel clusters what we found, one is the IROD, that is the insulin resistant. They are having, of course, high BMI and waist circumference and high C-peptide levels. And the third group, which is very difficult to control because it is the combination of both insulin resistant and deficient diabetes. Now, this is the clinical and biochemical characteristic of various types. I mean, you can say it's working. No, it's not working. Yeah. So we can see the age of diagnosis, as already I have mentioned, the MARD group, the maturity, mild age-related diabetes is the maximum with the, elder people, the 50 years. With the youngest one having the SERD and the SID group. If you look at the waist circumference, the highest with the IROD, insulin-resistant obese diabetes. If you look at the HbA1c, this is the most difficult, the severe insulin-deficient diabetes with 10.7. Then next comes the SERD, the 9.1. The best A1c with the MARD group, this is because this is a mildly, age-related diabetes. Similarly, if you look at the triglyceride, it is highest with the SERD group, 351. If you look at the HDL, the best one with MARD group, and with the C-peptide, of course, the severe insulin deficient, so the least with the SID group. Now we have discovered the 2 new novel groups and the old 2 Scandinavian clusters. But the important point is whether this can be replicable in a national levels. So what we did, we have the ICMR INDIVE study, where we have 4,000 representative samples from each state, 15 states and union territories. These are the variable which instead of 8 variables, here what we have used 6 variables: age at diagnosis, BMI, waist circumference, HbA1c, serum triglyceride, and HDL. By looking at, because C-peptide is not possible, it's a costly affair, so it cannot be possible to make it in the national levels. So we have used 6 variables. Now what we found, the similar kind of results. So we can see that the INSPIRE study results, the 4 cluster, it can be validated in a nationally represented INDIVE study, because the INDIVE study is one of its kind study where all the 28 states plus 2 union territories, National Capital and Territory of Delhi, all the population. You can say it's a pan-India population, it's a representative of the pan-India population. So these 4 clusters, it can be validated in a INDIVE study. Now the INDIVE study, they shows the clusters identified in the clinic population is replicable and it is stable in the national levels. Now we have discussed about, we have found 2 new clusters and the total 4 cluster, but what is the clinical relevance? Because as a clinician, it is important if there is any clinical relevance. When you see the complications, when you found out the complication, you can find out the retinopathy is highest with the SID group, that is severe insulin deficiency group, whereas the nephropathy, it is highest with the third group, which is a combination of both insulin resistant and deficient. The CKD is highest maximum with both IROD, insulin resistance, obese diabetes, and the combined insulin resistance and deficient diabetes. So what is the clinical significance? If at the beginning, at the age of diagnosis, within 1 or 2 years, we can subclassify the type 2 diabetes into these 4 clusters. Suppose somebody is coming with SID group, SID cluster. So we know this group of population, they are more prone for retinopathy. So that we can advise the patient for an annual retinal checkup. We know the CKD patient, the IROD and the third group, they are more prone for the CKD. So we will be more vigilant in our, regular, calls or the review calls, so that we can look for those complications. So that's the clinical relevance. Now these are the list of diabetic clinics that participate in this study and that local, locations. Now, after finishing this step, now we have tried another thing to look at the clinical relevance, the prescribing patterns and response to anti-hyperglycemic agents among the novel clusters of type 2 in Asian Indian patients. In this group of patients, what we found among the more than 32,000 participants, the most frequently used anti-hyperglycemic agents were sulfonylurea, metformin, or the combination of both, and among the newer agents, the DPP-4 agents. While there is significant difference in the A1C reduction between the drug across the different clusters, but they are mainly driven by the difference in the baseline A1C. The highest, high is the baseline A1C, the more is the reduction in the A1C. Now this is an ongoing trial. We are conducting the aggregate study, which is a 24-week randomized controlled trial, which assess the effect of glimepiride, metformin, vildagliptin, and dapagliflozin on the glycemic control in novel subtype. The phase 4 is right now. We can expect the next year the result to come out, so that we can even enlighten more us on this, which group of anti-diabetic drug acts best in which cluster of groups. So that we can say, in other words, we are moving towards a precision diabetes. We cannot just waste our time just like we are doing it. A patient is coming, we are starting with metformin, then we are adding the sulfonylurea or SGLT or DPP-4. But if we can say that which cluster a patient belongs to, which clusters, then those group of patients, they will respond to which group of anti-hyperglycemic agent. So from the beginning itself, without wasting the time, the valuable time, we can go directly from it. So hit early, hit it hard. Now these are the advantages of clustering of the diabetes: to accurately subclassify the diabetes, to plan therapy based on the pathophysiology rather than to consider all the type 2 diabetic patient as a homogeneous condition, to predict the prognosis and prevent diabetes complication in future, and to approach our patient in a precision diabetes manner. The summary: for the first time in India, clustering was being done. We have found 4 different clusters. Out of these, 2 the same with the Scandinavian cluster. The 2 new novel clusters we found out, that is the SID, IROD and the SID. These are the 2 novel clusters. And our finding suggests the traditional anti-hyperglycemic agents, they are still continuing to enjoy wide popularity, but the effect of the newer anti-hyperglycemic agent like SGLT2 inhibitors, we have yet to find out in the aggregate study what is the effect on these clusters. We need more randomized clinical trial to confirm the differential drug response between the 2 different clusters, their response. But what I mean to say, till now what we have seen, that from these clustering, suppose a patient belongs to mild age-related diabetes, these are the older patients, they are very easy to control. So we can start with something to mild agent, but we will find the SID group, severe insulin deficient, from the beginning, younger age at onset. So maybe the early initiation of insulin will be helpful in those group of patients. So thank you all for your patience hearing. Thank you.
Thanks, Dr. Philip, for your nice talk. already the time is short, already it is 2 p.m. So I think if we will avoid the question and answer session, it will be better. And only one question can be allowed. Otherwise, if any question, you can ask during the lunch time to the respective speakers.
Actually, Dr. Philip is the consultant who closes the academic program of the conference. The hall B already have closed, and now before valedictory, it's not a question, it's a comment. This particular approach, why I kept this topic and scientific committee recommended, we have to change ourselves. In the diabetes, we are seeing patients day in and day out. Do we know from type 1, type 2, now what we are following is from IDDM and NIDDM. We know when we read IDDM and NIDDM. There is a concept of insulin dependent and non-insulin dependent. Still, old consultants, they write like IDDM and NIDDM. I have seen gynecologist, surgeon writing IDDM and NIDDM. From that, in 97, we went to type 1, type 2, type 3, type 4. And now, if you see this, it makes not only a pathophysiological basis, changes your approach to the patient. What we are discussing, now guidelines are changing, we are approaching patients basing on the pathophysiology. So, this particular classification will be accepted today or tomorrow by the global authority and will come to us. There is no doubt in that. Only thing, because it's starting from India, it may be a little late. If it would have started at US or UK, it would have been earlier. But we will be able to convince the world authority regarding validity of this pathophysiology based classification. So why not in our country we'll start following, brand this diagnosis, so people will realize what is this, what is SIDD, what is this, and then how should we define that, number one. Number two, another request to Dr. Philip, through Dr. Mohan Center, you sent a proposal from RSSDI, which topic we had kept but we could not do because one of the speaker dropped, we could not do. That is, the complications of diabetes should also be reclassified, not microvascular, macrovascular. Long back we thought that complication can be either macrovascular, when big arteries are involved, or microvascular, like retinopathy, nephropathy, neuropathy. So this is a very broad classification, and now we know much more about complications. Yes. You see, when you tell diabetic foot, it's a micro as well as macro. When you tell about a stroke, now we know the basis of complication which is beyond this vessel size. So it's time to reclassify diabetic comorbidities and complication also, and also the diabetic classification. That is my last comment, and thank you for the good presentation. Over to Chairperson, sir.
This is the end of the session and we conclude it.
I request the speaker and chairpersons to come to the memento bay for the mementos. I thank all the speakers, guest speakers, as well as delegates for waiting so long. Lunch is already, they've started the lunch, but there are many people in the hall. And quickly we'll finish up the valedictory. Everything will comes to an end. And those who are good, one day it comes to an end. And I congratulate the whole organizing team for such a successful event. And we'll have a very brief 10 minutes valedictory before we close the conference. I request our President-elect, Dr. Goenka. I request our Treasurer, Dr. Sandeep Devashish, and I request the Organizing Secretary, Dr. Santosh Swai, to come on stage, and we'll have the valedictory function. 80. Okay, we can give here. Yeah. Perfect. So Philip is lucky to get a memento in this stage, because many people they have dragged to the memento bay. Actually, we are all old timers. There was a trend, and the felicitation was very important part. Then from stage it came upstage. So now upstage to a distance, and many people forget to call also. Many of our national and international faculties have left without taking memento. I don't know how to send those mementos. So that is losing importance. So give a big hand to Professor Dhar, who talk about non-nutritive sweetener, one of the most controversial topic for last 5 decades among the diabetologists. And Dr. Thakur has come all the way managing his works at the VSS Medical College. He is a very important member of the team. Congratulations. And of course Philip. Yeah. When I tell Philip, many people ask he is from UK or US or Australia, which country? I told no, Odisha has also Philips.
Thank you. Thank you.
And the name Philip itself gives an international touch to the program.
Thank you.
Yeah. Chairpersons have got the chairperson? Chairpersons, kaha rahe? देव भाई देवी दत्त अच्छा अशोक बेसी अच्छा मुझे देखी अशोक महांती अशोक बेहरा अशोक प्रधान अशोक स्वाई देवी देवी हाँ कम thank you for coming, thank you for taking your session. Ashok. Thank you Ashok. And important responsibility of hosting this year's midterm CME is given to Dr. Ashok Behra at Balangir. Hot sheet of HOD Bhim Bhui Medical College, Balangir. Congratulations, sir. Sir is the permanent treasurer of ARO Association, the Obesity Association of Odisha, All India Association for and he has been part of all our scientific programs. Please give a big hand for the last team of faculties, including chairpersons and the speakers. Thank you, sir. Thank you. Okay. So I invite the office bearers. ये कहाँ उड़े volunteer कहो इस chair उड़ा कहो मुझे की नहीं ऐसी hall volunteer के प्रशांत ऐटी के बुले दियो ये सर पड़े सो ग्रुप दोबारा नहीं Dr. Sanjay Das here? Yeah. Please come. Please come, sir. Vice presidents are very important. The day US realized that president is not competent to recognize his own wife, then Kamala Harris became not only important, became the candidate also for the presidential race. So vice presidents are very important when the presidents gradually start dementing.
Harivallabh Mahapatra.
नहीं संदीप देवाशीष संदीप हाँ हरिवल्लभ नहीं ठीक है हरिवल्लभ असले हाँ हरिवल्लभ क्या
Dr. Harivallabh.
या हरिवल्लभ महापात्र मैंने हेड headquarters is enjoying the. So now, quickly, it's a 10 minutes procedure, and the most interesting part is the prize giving. So first we will start with prize giving. Then I'll request one invited faculty and one state faculty to tell their opinion, and we'll close the session by thanking the organizing committee. So the result sheet, Devashish, the result of the free paper and quiz to be announced. Meghnad, Dr. Meghnad. Result লিখিছ नहीं क्विज आई नो बट फ्री पेपर तो नाटा देखो ना दियो मत दियो So first we'll start with the free paper presentation, and the first prize goes to 2 doctors jointly. We had received good number of free papers, and we decided to allow all the free papers as platform papers, because they are good papers in quality, and by presenting you have a satisfaction. And good that our judges are impressed and people attended are very happy about quality of presentation and the content of the papers. And first and second prize both came joint of almost 4 doctors, 2. So first prize jointly goes to Dr. Kishore Behera, All India Institute, Bhubaneswar, and Dr. Rosalind Parida, SCB Medical College, Cuttack. So I invite the first prize winner of free paper on stage. Please come, both of you please come. Prizes are ready? Yeah. Kishore, come. So I request all the office bearers to please stand. Come here. Congratulations. That is the attitude of a professor HOD endocrinology, All India Institute. He not only came and participated, he presented a paper and got a prize. You see, with our postgraduate, HOD endocrinology of AIMS Bhubaneswar sharing the prize. So we salute the spirit. Give a big hand to Dr. Kishore Behera. Congratulations. Rosalind, come. So I am proud. I am part of the paper she has presented. I am her thesis guide, and we had a work on CGM, which has been awarded first prize. So being part of the project, I am proud. This is a case prize that you get. No, it's not a sponsored project, but we can adopt it. Yeah. Congratulations. Congratulations, Rosal. Then second prize, again we have very interesting combination. One consultant and one postgraduate, what I see here. Dr. Mahesh Rath from High Tech Medical College, the faculty in the Department of PSM, High Tech Medical College. Not only he presented a paper, he got an award also. And give a big hand to Dr. Mahesh, who shares the prize with Dr. Prachi Dhar from SCB Medical College. Good. No, you come here. Yeah. Congratulations, Dr. Mahesh Rath. He is part of the event and done many more works, but it goes without conflict of interest that he has scored the prize. Dr. Prachidhar, yeah, please come. And what I see, Dr. Prachi has also got the first prize in medical quiz. So, congratulations for winning double prize. Yeah. And fortunately, I am also her thesis guide, and I am also part of the prize. So I congratulate both of them for making us pride. Congratulations. So, yeah.
Your prize.
I would certificate. So you are getting two prizes. So give a big hand for the double prize of Dr. Prachidhar. She has got
Best quiz then.
5,000 rupees in quiz and 4,000 rupees in paper. So he is getting 9,000 rupees. Congratulations. Congratulations. And the second prize in the quiz goes to Dr. Shurabhi Mishra from Postgraduate Institute of Medical Education Research, Capital Hospital. So please welcome, give a big hand to Dr. Shurabhi. Yeah, welcome. You are a DNB trainee? Yeah, PG, postgraduate. Namita madam pakhare acho? First batch. Namita madam pakhare. Good, very good. Congratulations. Congratulations. So they make us proud and add to the academics. Please take your seat. So this is a very important part of the conference, and that we had 3 papers and quiz, postgraduate quiz, and I congratulate all the winners. Keep up the spirit and the right spirit shown by Dr. Kishore and Dr. Mahesh, that even they are very senior consultants, they have presented paper and own prizes. Give a big hand for everyone. So now it's time to listen to the experiences. I invite Kalpana ma'am, who will represent the invited faculties, out-of-state faculties. I invite her on stage. Briefly tell your experience of the conference, and anybody from the state. Professor Swai here. So we'll listen to him. Madam, quickly. You can come here. On the mic on kar de.
So there are 2 experiences. One is personal and second is professional. So personally, if you ask me, is coming back home and giving lecture and enjoying with my own people, there is no word. It's just enjoyable and no words for that. And as far as the professional experience, I would say the academics that we do here in our state, there is no match. I always tell my fellow people, if you go to Odisha and attend one conference, especially all conferences, those who are organizing the kind of scientific content and the communication, everything, always it is beyond imagination. I would say, if you ask me to give a number in our country, maybe it should be 10 out of 10. So
Thank you, madam. Thank you for your precious words.
Congratulations to all of you. Okay.
Thank you, ma'am. Thank you for coming, participating, and appreciating our activities. Professor Swai. Professor Swai is a very senior physician. He is the ex-chairman of RSSDI and the present chairman of API ODISHA. He has come right from the day zero and with us, encouraging, participating, and giving his comments. And today his presentation on elderly diabetes and elderly was one of the best presentation with best of the fact, covering all the aspects of an elderly person. Professor Swai.
Thank you very much for a part of the conference. to organize a conference is a Herculean task, you know. And with the vision, dedication, perseverance, and sincerity, Professor Jayant Panda, Dr. Santosh Swine, Sandeep Devasis, Goenka, and Sanjay and Hariballabh, all in the dais, and Rath, where is Mr. Rath? And all have devoted a lot of time. Not only them, because of you, the delegates, you the speakers, you the chairpersons, this academic feast has become marvelous. Without everybody is important. Everybody's participation gives an immense knowledge and academic excellence. And this academic excellence is needed to brush our knowledge and fulfill our deficiency and enlighten ourselves to give a better prescription. And that is for the betterment of the society. We will enrich with the knowledge, we will fulfill our deficiencies, and we will be a better doctor. Because to become a doctor, you must give the best of knowledge of medicine and best of the science, most updated, most modern, and everything that fit into giving the best prescription to the patient. Because patient think you are a demigod. He's coming back to his life and shifting his difficulties and disease at the back seat because of your healthy prescription. So this academic parameters is excellent. The venue is of paramount importance, and also the food and the hospitality provided is also very excellent. And we pray that such conference will go on, and the academic excellence would be in its forefront, and all the participants must grow in large numbers, because we don't find much participants with the age of 30 to 50, where they are, because most of the delegates and the speakers and the chairpersons are above 50 to 70 or 75 or 80. They are outnumbering the youngsters. Where the youngsters are there? Only postgraduates, a few postgraduates for the poster presentation or paper presentation, and others are staying in for a practice. What do you practice? You practice wrongly. The patient will go to a consumer courts, you know. So you must come with the knowledge to be safe. So, and the patients will be in the safe hands. That is very, very important. Give the message to the youngster.
Sir,
They must attain in the future. Thank you very much.
Very well said, sir. Very well said. Sir gives a very important message. I was telling the other day what I was doing 25 years back, I am doing today. I want whom to give the baton. All of us are growing old, but the youngsters must come forward to take the responsibility from us. So Professor Swami gave a very clarion call for the young mass to come participate and take over.
One invited speaker told me, Dr. Swami, Dr. S.N. Swami is your father? No, more great father.
You see, in a lighter mood, there are two problems with invited speakers. First thing, they don't understand the title Swami. Swami is pure Odia Asmita. If you pronounce it in the English, it becomes Swen. Swen. So they mispronounce the word first. Second, when they come, they find two people with the same surname, they try to connect. So I'll just summarize in one word. This effort started last year in the last RSSDI conference that we will do the event in Puri, because we had done a successful event in Puri 8 years back in 2016, and Dr. Swami took the responsibility with coordinating the Puri team, and the headquarter wanted that it will support the team from Cuttack and Bhubaneswar. And there are many challenges because venue itself was not ready, and you know, so many conferences are happening. Mobilizing fund is also challenging, And you see, every weekend there is something. So getting faculties are also difficult. Many people are moving, and unless you have a very close interaction with them and block them early, they don't come. They are diverted. You see, simultaneously there is a thyroid society program in SGPGI, Lucknow. There is a diabetes program in Coimbatore. Suresh Damodaran program is going on. There is DID program by Sean Pharma in Mumbai, which is a national program. There is a Shafi program, South Asian Federation program in Sri Lanka. So simultaneously multiple programs are going on. But still, even President RSSDI kept our request, cancelled his Sri Lanka trip and came to us, delivered oration, became chief guest in the inauguration. So I must thank all invited faculties. I must thank all state faculties, chairpersons and delegates who are in huge number have come, participated and enjoyed the program, who has made the program successful. Workshops were out of the box, very good interaction, everybody is benefited, faculties are happy, attendees are happy. Pre-conference program went very successful. Conference program, plenary, orations, people have enjoyed, and the free paper, the quiz, and program in all halls, along with the ambience of the place, the hotel, the stalls, the inputs given, everything was much appreciated by our delegates. So on behalf of RSSDI state headquarters, I'll congratulate the organizing team, especially Dr. Santosh Swai and Dr. Harivallabh Mahapatra for their commitment. And I'll thank all, especially sponsors. They have come, they have participated, they have taken care of the delegates, they have displayed, the exhibition was done, and I'll request Dr. Santosh to special thank in his Thanksgiving the sponsors and those all who have helped him and all our team on behalf, because I don't want that we should speak more and waste time. On behalf of President-elect, on behalf of Vice President, and on behalf of Treasurer, all our central state RSSDI, I thank organizing team. And before we close, I tell Dr. Santosh to do a Thanksgiving to all who matter. We'll then close the meeting. Over to Santosh.
In last year's RSSDI 2023, I, along with my younger brother Harivallabh, were given the responsibility for organizing this conference at Puri. The venue was still not decided, and around 6 months passed. We could not decide what to do, where to do. In the last 6 months, we detected this place, so we were able that this may solve our purpose. So we logged partially, but still the owner were not ready that you may not get the property at time. So that was the most big challenge for us, and with the blessings of Lord Jagannath, it could happen. In the last 1 week, they have come up with this nice property. So that was a added benefit. The ambience, the space and the arrangements added to our credibility for successful conference, and 50% of this conference was due to this place and ambience, and our team left no stone unturned, and we had no doubt we have spent some sleepless nights, but we could achieve this level. And in that journey, the RSSDI Odisha chapter headquarter have always bestowed the support in time and need. The pharma sponsors have participated and supported financially, so we could achieve this target. The audiovisual team, the media team, all the support staff, the registration was well managed by the micro people, and we could design a trade area, and we have put an AC in that. So all the sponsors are telling that you have provided us comfort. That is great. Also, due to our constraint in the food menu, we could arrange separate lunch for all of these farmers who have sponsored and participated, and they have appreciated it a lot. And finally, for this conference, the day before this conference, I had went to that temple and I have submitted this conference to the Lord. So I have the faith and I have succeeded. Thank you.
There are two important things what Dr. Swain told, that air conditioning the exhibition hall, and second, providing food for the participants of the exhibition. You see, it's a challenging in a star hotel to give food for everyone. We definitely want to give food, but it costs very high when all the volunteers are included, and there are many volunteers in hundreds who need to be given food. The organizing committee decided that if not by the hotel restaurant or caterer themselves, by another caterer we can arrange special food, and that they have arranged and given. And second, spending a good amount of money. The exhibition place is air conditioned so that the participants and the delegates both can spend a comfortable time. And that's an extra expense for the organizing committee, but they have done with a good gesture, supporting the people who support the event. And then Shamim has done a marvelous work. Satya and Bibhu have done marvelous work taking care of the Hall B and the virtual hall. And especially Signova is a farmer from Assam-based farmer. They have come over, participated, and hosted yesterday's banquet. It was a big program, taken a big exhibition space, launched in Odisha. They've shown a very good gesture. Micro did, as usual, registration very flawlessly and supported the bag and registration kit, which was appreciated by most of the delegates. USB, starting from the virtual room to the webcasting of the whole program, faculty lounge, and supporting the conference and doing a stall, everything they have done. Sun Pharma has also liberally participated, getting the delegates and supporting us in many cause. Besides the Alkem, the Lipur, Lupin, all have come forward. And besides, people who could not spend more, but they kept their presence, are Pfizer, who promoted only one pneumococcal vaccine, but was there. It's an international company, they were there. Sinocare, they promote a CGM device, but they were there discussing. So they're focused. DietAssure, they are into the nutrition, they were there. So I thank all the participants in their capacity who have come and delivered. The travel is single-handedly managed by the Sanjukta Travel, Mr. Shorup and the team, and also our volunteers from USB like Pradeep supported, and all have been given adequate support. Glenmark, with all the divisions, have participated very well. Alembic has participated, and then Novo Nordisk has participated, and Intas has participated. Danone has participated, though they have a guideline not to participate in conferences. They came for pre-conference program and participated. So all the sponsors, I'm not being able to take the whole name, but all the sponsors I must thank on behalf of RSSDI Odisha, Sistopic did a marvelous job reaching every consultant in the different villages and the cities, and they coordinated the registration part. So their time was short, but everybody's contribution could make it a successful event. So without taking much time, so final comment from our organizing secretary.
Actually, it's a pleasure for us that the whole team is there, but because of the indubitable contribution towards the organizing committee, the team of Puri RSSDI, they want to present something to Professor Jayant Panda, sir. This is a small token of appreciation. Please accept, sir.
Actually, we thank heartily for the gesture. Actually, we felicitated our invited speakers. We also felicitated our organizing committee. I felicitated all the participants, like the hotel people and the even Barshana, who performed Odisha yesterday. And I must thank the event team, especially Suraj, Prabhat, Vishal, Dibya, Manoj, who have worked day and night last moment. And also we had Aditi at the beginning, Rajesh supporting our Shinu, and Shiva supporting the tent. So the event involves everyone. So every good thing must come to an end. So with this, we declare the conference closed and looking forward in our midterm CMEs and the future conferences. Just to remind, the GB has decided next conference in Cuttack. Details of the venue and the organizers will communicate soon. Please fix your mind for the next conference. So similarly, we can make it a big success with 1,000 footfall at Cuttack. And midterm CME has been fixed at Balangir as a Western Odisha place, because we have not travelled Western Odisha much, and it was decided that it will be in the medical college, Bhima Bhoi Medical College, and Dr. Ashok Behera is given the responsibility. So quickly we'll tell you the date of midterm and details of the program, and also next conference at Cuttack and details after finalizing in Arish. Thank you again. Thank you very much for your presence. We invite all of you for the lunch, and then we'll be departing. Thank you all. I invite everyone on stage. All the faculties, all the volunteers, all the office bearers, all the delegates who are here, please come on stage for the last photo. We can tell it last photo of the conference, where everyone are there. Aso, come, Santosh, please come. Last year, Sanjay, come. Atanu, come. अच्छा आसो फोटो फोटो मिनट लास्ट फोटो एंड आसो आसो ऑल किशोर कम कल्पना मैडम श्रीकांत प्लेट रखी देगी शिशिर सर सुरेंद्र सर प्लीज कम लास्ट फोटो Actually, this is a trend now that all who are till end, I will not use the word left out. All those who are till end, they take a photograph.
This is the closing photograph, not the last photograph. So we are afraid.
Valedictory photograph. Valedictory photograph. WhatsApp रे आसुची ना लास्ट सीन सर WhatsApp रे आसुची ना लास्ट सीन WhatsApp रे लास्ट सीन आसुनी
Here, in a lighter mood, I'll add.
And your prize is the chocolates.
And then in lighter mood, I'll add Professor Swai. While introducing Professor Swai, don't tell he is the past chairman. Tell that he is the future patron.
Yes.
So that's a positive introduction.
And we'll give to this is Kalpana, means your future for future patron. So I am presenting another.
Only to ladies. Okay. Thank you everyone. Thank you volunteers. Thank you sponsors. Thank you partners. And looking forward to meet you again. Thank you.
Kalpana.